Good morning, everyone. I'm just going to start the day off right.
Oh, yeah, the goat.
The goat.
The goat.
The goat. The goats are back. The goats are back. Okay, welcome to PerfWeb 102, day one.
Day one.
Yeah, okay, I got it
Yeah,
right.
yeah, yeah.
Finally. Hey, Josh, has anyone else had difficulty signing up to receive CEU credit for this? Account creation seemed to not be working. Can we respond to this, please?
Magic.
Thank you. Okay, Josh, we're going to address this issue. We hate the fact that anybody's having problems, but if anyone else is, please let us know. We have our team working on it right now to try to figure out what the issue is. So please forgive us if there's an issue on our end. To contact us, contact@perfusioneducation.com. And we're going to kind of blow through this today, folks. We're going to try to limit the time wasting that we do sometimes. And we're also going to take a 5-minute break between the lectures where we have my dear colleague and now co-host of this program, Dr. Samir Patel, Perfusionist extraordinaire. Very, very, very pleased with his commitment to education. You know, it's not for everybody, and I do understand that. Sometimes I try to force people into this because I particularly view it as having an enormous amount of value, and I just think it's an important element of what we do, and part of what we do should, I believe, include education. I believe that. I don't know how you feel, but
I feel that way.
most of the presentations I give, I probably learn more than the people that are listening to me.
Oh, this is so true.
And
when preparing these things, you get brushed up on topics that you don't know. You don't remember everything, right? They teach you a lot of this stuff, right?
Yes.
But who remembers that? You only remember the stuff you come across,
and
right?
you're using.
And you're using, right?
You're using.
So I mean, it's good. I get a lot of stuff out of it. It's not. So I'm not just doing this for you guys. I'm doing it for me too.
Yeah.
And my board exam on Friday.
Yeah. I know you're gonna do fine. You're gonna do fine. But if you do, you know what? Don't even stress it. You know, whatever.
Yeah.
I think that standardized tests are standardized tests, and I know so many people who are so incredibly capable, but they just can't take a standardized test. I just don't think that it's the best reflection of somebody's information.
Tests.
Our call-in number, there it is, 832-239-5358. That's 832-239-5358. Our Chiron will stay at the bottom here. I'm not going to do a demonstration of the app, but this is what it looks like. Look at it, review it, take a peek. We've had a couple of which really disappointed me because, it's a brand new app and it takes time to get anything, that people want to buy anywhere because it's so much competition out there for everything. But we did get a couple of negative reviews, which I thought were grossly unfair. So it skewed our numbers really bad. Frankly, I think it was, I believe it was deliberate, but I have no proof of that. So it's just my speculation. But regardless of it, check it out, and you know what, if you get it, you spend $2.99 and you hate the app, call me up. I'll give you your money back. It's like, I don't even care at this point in time. I want you to, minus what Apple and Google takes from it. So the $2.99, by the time it gets to me, is probably only about $1. So, they take a lot of that money. But that's why we had to do that. I mean, it's just, we have to do something. But with that said, check it out. Okay. That's all I'm going to ask. PerfWeb podcast. You can go to your favorite podcast streaming software, wherever that is, Spotify or Podbean or whatever else there is. Podbean or Podbeam?
Podbeam.
Beam with an M? Podbeam? Bean? Like a bean, like
bean,
a green
like,
bean. Oh, okay.
Exactly,
So
like
it's like a green bean pod.
Exactly.
I
Podbean.
get it.
Yeah,
Okay,
yeah.
cool. All right, well, I didn't know that.
Mm-hmm.
And that there you can listen to our podcasts.
Yep.
And hopefully Josh, your problem got resolved. If it did, please let us know. If it hasn't been resolved, you can use that call-in number and call in. We won't put you live on the air, but they can still talk to you back there and possibly help you with your issue if you're having that, because there's a lot of different places you can be watching this program. Okay,
or
so
we can put you on the air if you want to.
Yeah, that would be nice too. That'd be nice too. I'd love for everybody to do that. However, and with that said, we are where we are right now, and we're going to be discussing two really important topics today. That might be Josh.
Might be him.
Don't put him live on the air. Just answer it.
Hi there.
Let's see who that is.
I was trying to create an account, and
That's him.
it just seems to be resetting every
I
time
asked you
I
not to put him on
do.
air.
Don't put him on the air.
Oh. Well, no, you popped the number up. You should have just told me, change the number to something else.
Or have Magic call him back on the number he called in from.
Yeah, go ahead.
Yeah.
Okay.
Josh,
All
he's
right,
gonna call
Josh,
you
we're
right
calling
back.
you back.
Yeah.
Okay, so apparently you called in on a number that is that number will only work apparently live on the air.
That's right.
So I made the mistake. I
Yeah.
just have to, I don't have any
Joe
choice.
said it, and our
Listen,
producer went crazy.
Josh, my
He's
Josh,
like, no.
please, Josh, please don't apologize. Now Josh is apologizing. This is falling apart today.
This is falling apart.
Okay, we came here to be serious about two serious topics.
Very serious
And
topics.
now we have done nothing but devolve. All right, is this what you expect out there? This is how we are. Okay, so if anybody wants to know what perfusion is really like,
Rolls downhill, Joe.
this
It
is
rolls
how
downhill.
it is. We can be super sophisticated, and we can certainly operate in the realm of pretty much anybody that you want to operate in. But at the end of the day, when you just distill us all down, perfusionists are just a bunch of crazy folks that just have fun with circuits.
Right.
And so here we are. But with that said, we know a lot. We know a lot. Tell you what, we do a lot. But two incredibly complicated and difficult and important topics. Major organ autoregulation thresholds. This is very important. I do cases at multiple hospitals, so I could be in any one of 7 hospitals doing cases. And at one of those hospitals, the surgeon wants the perfusion pressure kept above 80, and if the patient has any kind of PVD, cerebrovascular disease, or is over the age of 70, he wants the pressure at 90. And these people
That's a lot.
pee, but that's normal.
Yeah. Normal,
The problem
correct.
is when surgeons look up and they see a pressure of 80, 85, 90, that some of them are like, why is the pressure so high?
Right.
Well, it's not high. It's actually normal.
Right. 93
See,
is normal, people, for 120 over 80.
And and if you're
Right.
hypertensive and you're used to a higher
Right,
drive,
exactly.
So those patients, my whole point of this
Yeah.
is that at that hospital, our urine output is 3 to 5 times more than it is at hospitals where they want the pressure between 50 and 60.
Sure.
And so that is so I could be flowing a DO2 of 280. I could be flowing a DO2 of 320.
Right.
DO2I
Right.
of 320.
Right.
I could be doing all kinds of things.
Right.
But the patient's not going to pee
No.
if the drive pressure for the urine production in the kidney,
Right.
the delta across the efferent and afferent arterioles
Right.
is not sufficient. It's not going to produce urine.
No, I mean, your JG cells will sense that there is no pressure. They'll
So here we go.
start
That's
wanting
why
to secrete renin too, and then further
complicate
matters by
Yes.
then
So-
keeping more volume inside instead of having it go out.
Correct, because it perceives. We talked about organ crosstalk. We keep talking about organ crosstalk. I think organ crosstalk is a grossly misunderstood or unappreciated phenomenon that does occur. And so we keep
Totally agree.
trying to reduce this renal problem that we have, which is AKI rates that are too high in cardiac surgery, have remained too high. Stroke rates are too high in cardiac surgery, frankly. But, you know, I mean, all of these things are they clinical strokes? Are they just, you know, but any stroke will have long-term deleterious effect on a person. Right. Even if it is so subtle and you really can't see it, it's there. And people that know those people best are the ones that have that experience with them. Now, back in the old days, they blamed the heart-lung machine for it. It was called pump head, and that came from the Wall Street Journal. Right. But that was incorrect. They have since learned there are other things. But what do we do? How can we help to facilitate reducing this problem? You know, you clamp the aorta, you manipulate the aorta at all. You know, there's air that gets everywhere, theoretically CO2, but there's even air that gets everywhere, okay? And so there's a lot of...
get dislodged.
There's so many factors,
yeah.
so many things that we could be doing to make things better. Of course, that's why the EOPA cannula is so popular, because you can put it in the ascending aorta and traverse it around so that its outlet is distal to the subclavian, thereby reducing your risk of cerebral embolic events from the pump, not necessarily from even jetting, perhaps, because you could have jetting against the wall in the ascending aorta and knock off some atheroma or whatever. That can happen too. So this might reduce it in that regard, but it's not going to help you when you have to clamp and unclamp the aorta.
Still has those like dispersion tips to try to help with even the jetting.
Yeah, to some degree.
To some degree, but it comes more like the clamp people underestimate, right? Like
the clamp, even picking the heart up, just picking it up and putting it down. Exactly. All of that is distorting things.
Right.
And of course, when I talk tomorrow about the right heart failure, that distortion happens a lot with certain aortic valve procedures. You can almost anticipate that it's going to happen, you know, when they, but when they don't see that they bagged the right coronary, man, I'll tell you what, the time it takes you to figure that, for them to finally figure that out, sometimes the right heart's never going to come back. And so it's a big problem.
Seen that.
It is a big problem. Exactly. I know. I think we
in my limited career, I've seen it a few times.
Exactly. So please forgive me for all the jibber jabbering, but I was trying to give Josh an opportunity to get whatever his thing was figured out. So that's why we had kind of this bantering going back and forth this morning, if you don't mind.
Which we weren't supposed to do, but we did.
We did. But, yeah, because, well, I'm trying to, look, I mean, I'm customer-centered, okay? I'm customer-centered.
Customer-centered.
So let's go ahead and get started with major organ autoregulation by Dr. Samir Patel. Thank you very much again for being here. It's always a privilege and a pleasure.
Absolutely.
Please, the floor is yours, sir.
All right. Thank you, Joe. All right, everybody. So what are we tackling today? I think Joe kind of told y'all, you know, you got to think of this as like the mission briefing before like the perfusion spacewalk. You know, you got to, by the end of the session, you should be able to define what autoregulation is, identify organ-specific pressure ranges, the spot moments that, you know, can delicate the balance of when things are about to go off the rail or not off the rail, you know. So we're going to move through this organ by organ, brain, heart, kidney, liver, and that's kind of the only real way to do it. So first we'll start off kind of just talking about it in a general sense and then move forward. All right, so let's get started. So why does this matter? Okay, autoregulation, right? Sounds like a fancy term. Sounds like something you hear in like a car commercial, you know, now built in with autoregulation. But in medicine, as Joe said, you know, these topics are important. So this one is a huge survival mechanism. It kind of lets organs maintain perfusion in the face of shifting pressures, you know, which happens all the time. I mean, here we are talking about them lifting hard, stuff like that. What do you think that's going to do? That's going to move pressure around, change stuff. So the brain itself, you know, we're going to get into it in a second, but very, very sensitive little organ. It doesn't like changes too much, so it'll do its best to maintain stuff as baseline as it can, you know, right? Even it'll do that, you know. So on pump or ECMO, these normal, like, homeostatic signals are like the window, you know. You're the one to keep perfusion in the safe zone. So remember that this is not just on pump, it's on ECMO, it's on any type of ECC. or even as we, are in a regular body, like if you're swimming or stuff like that, pressures change. If you're going up in altitude, pressures change. Things change. I mean, hydrostatic pressure.
Yeah.
So what is autoregulation? So think of autoregulation like a thermostat for blood flow, okay? With each organ, it just adjusts its vessels to kind of maintain flow. So as long as the pressure is within a certain window, and that's the key, it has to be within a certain window. Too low, and the organ will say, I give up. Too high, and it'll say, like, I hate you. It'll just stop. Either way, you miss that window, it's game over for autoregulation. And the consequences are usually dire, okay? They're once you lose autoreg, it is not a fun day for whoever's involved in that case. So just the organs at a general glance. This is kind of like the cheat sheet. If you want to memorize anything today, this is it right here. It's what I memorize for my boards. It's these are the numbers you want to know. The rest of it, whatever, but know these numbers. The brain, like I said, it hates change.
Wow.
So it keeps a long, big range, like maps between 60 and 150. The heart, it can kind of get grumpy also, so it also tries to keep, a big range for like those diastolic drops that can happen all the time, 60 to 140. Again, the diastolic is key in this. Kidneys, they have high standards. They can go up to 80. They're just, that's how they roll. And it's funny because me and Joe, we were just talking about, these, Joe mentioned it, but where do a lot of these guys like to stay on pump? Where do these surgeons like it? They like it 50 to maybe 70, maybe even under 70. Some will even complain at 70.
Mm-hmm. And their concern, of course, is the clamp slipping.
Exactly.
Right?
And that's true.
Right. There is a reason, and I want to make sure that we are clear on that
Right.
I do understand that they have a reason.
Absolutely.
However,
right.
I have, this surgeon over here,
Right.
not having the clamp slip at 90, but over here, the clamp slipping at 75.
Right.
So is that clamp application? Is that just the type of aorta that's being applied to? Combination of both, I guess, could
Right.
be the thing. So how do you pick and choose
What to follow?
Which is the best? But go ahead. I'm so
Right.
sorry.
No,
Forgive me.
you're okay. So yeah, again, the kidneys a little bit higher, 80 to 180. They don't really kick in until about 80. So again, these numbers, keep in mind, guys, these are just kind of guide numbers that can always be plus minus 5. Each person's a little different. A lot of sources will say the brain autoregulation is good until 55. Some will say 60. Just depends on your source. Okay. The liver, again, usually a team player, not built for usually extreme conditions. It gets its source from the hepatic artery, 60 to 130. So, your role in all this, you're not just running a circuit, You're managing 5 organ systems with 2 knobs, a pump head, possibly a 3rd knob, some cardioplegia stuff. So, you're doing a lot of stuff with very little that we're given, okay? So when autoregulation fails, and it will, especially like we said with the kidneys, it's inevitability, Your decisions will determine whether those kidneys live to see discharge, or get or you're going to get handed off to nephrology in the ICU, and the same with the brain, liver and heart. Again, but the brain, liver, and heart, they have lower thresholds, so they deal with bypass a little bit better than the kidneys do. As Joe said, AKI, very normal thing, but that's because of the auto threshold regulations that, are that involved in the kidney. So think of it this way: you're not just adjusting flow, you're allocating resources, like on a battlefield. You're kind of like the general moving pieces around, and you got to protect what you can when you can.
That's an interesting concept.
And you got to do with what you can in the situation you're given. Obviously, a lot of surgeons aren't going to let you go up to that 80 that you're going to need to protect the kidneys. What can you do? They're in charge.
Yeah.
So
now
keep them happy.
But the argument, of course, is that it's short term.
Yeah, it is short term.
It is short term.
And they can take a beating, the kidneys, for the most part.
No, I don't think they can. Well, some can.
Some can,
but
Joe.
some can't.
Some can. Okay, yeah. So our patients probably can't.
You know, that's
Yeah.
the thing. You know,
Yeah.
the kidneys can take a beating, but that's not unlimited.
No,
You
and
know,
it's
you
not
don't
our
know where that
patients for
threshold
really.
is. Now, even though you may lose autoregulation, you still can have a flow. I'm sure you're going to get into flow dependent zones. So let me.
Yeah.
So let me stop. Let me let you work. I'm
Okay.
sorry. I got to stop talking.
You're okay.
No, I'm sorry. I do
Yeah.
that all the time.
We might not get into flow dependent zones. It's a little bit beyond. I'm trying to keep it more general.
That's okay.
Because we got to talk about 4 or 5 organs. If I get into specifics on each organ, we would be here for 2.5 to 3
Well,
hours.
maybe just a concept. You know, I think that'd be fair.
All right. So, cerebral autoregulation. Start with the brain. It's kind of the main guy that we need to protect. The brain is our original drama queen. You know, it insists on maps between 60, 150.
That's high, man. That's high.
That is high.
I mean, that's-
most people would pop one before
I mean,
then.
that's,
You know,
that's stroke level.
that is stroke level, but it still autoregulates.
Yeah, that's
It,
amazing.
it does. And I mean, we do a lot of things that change this, though. Keep in mind hypothermia, things like that. So you want to stay in that zone, and it's happy. Step out of it. Either go, you know, it's going to be bad. Never a good thing. Worse is that, like, chronic hypertension moves that safe range up. So your perfect map of 65, that's equivalent to, you know, what you think is good. Like Joe had mentioned in his patients, his chronic hypertension patients, that it moves your regulation. Now 65 might not be good.
Right.
You know,
right.
these guys have a higher threshold.
Right. Well,
So-
is there not what I said here was because somebody had mentioned they tried to do this with the patient and surgeons, no, you can't have it that high. It's bad for them or whatever. Mm-hmm. So I responded, you can maybe add to this or correct if it's wrong. If your organs are used to, I guess would be the right word. I spelled that wrong. To a higher pressure and has remodeled to accommodate that, then it will not function normally, or it's normal.
Correct.
So what I said was you
Yes.
you agree with. Okay.
Yeah,
thank you.
absolutely.
Okay.
And it's kind of unwritten there on my slide, and I'll show you all this. That chronic hypertension can kind of shift that the curve, the cerebral blood flow versus map, or you know, any of these flow versus pressure curves. It can shift it to the right. Okay, that means that the thresholds will also move, and let's get into that curve. So here is that curve.
Oh wow.
So okay, so
You know
here
you
you
can draw-
got
you can draw it
yeah.
too.
Well, yeah. I think
just make
I don't
sure
want to draw, but okay. So
Or you can just highlight by touching it.
yeah, nice. Yeah, that's kind of what I want.
You'll get it. No, just do this.
Oh,
Touch
yeah.
it and hold it, and then the that comes up.
Yeah, there we go. Okay, so first thing we're gonna notice here is notice that this curve is different than the numbers I kind of threw out. Right here, we got a 70. This one can auto-regulate till 60. Where this line is flat is your auto-regulation zone. Okay, so because his is higher here, we are left to assume that since normal used to be 60, he has shifted to the right, exactly like we said. So we can assume this is some kind of chronic hypertension patient. But that's basically what I mean by a right shift curve. So I kind of just wanted to throw this on there so you're not thinking like hemoglobin curve or
No, it
something
makes
like that.
perfectly good sense to me.
Right.
It does. I like this.
Yeah. So that's that. So again, if you're
Did this come out of Guyton?
it came off the internet, off of ResearchGate.
Oh, okay.
Yeah. So this, again, is our critical perfusion limit. We need to have that or things get real bad. Hypoperfusion. So this cerebral blood flow follows a lot like these last few days, few weeks I've been mentioning the Goldilocks zone, right? You want to be in a perfect area. Too low right here, you got ischemia. Too high, you got edema. Now you're going to be pushing all that flow somewhere. It's got to go somewhere. So, again, we want to be here. And in all honesty, you don't want to be on this side. I mean, let's just be real. I get that it auto-regulates, but, dude, you got a map of 140, 150. You will stress everybody in that operating room out.
No, it stresses me out.
It stresses you out.
I've
Well,
done
it should stress you out, including everybody else that sees it, too.
Ah.
It will not be a happy day for you as a perfusionist. Let's just say that.
great question, Yasser. Great question.
What did he ask?
And will address
Okay.
after lecture.
So clinical red flags for the brain. If you see NIRS dropping, that's not a suggestion. It's usually a scream. The brains won't wait around for you to adjust your flow nicely. Flat EEG, burst suppression, or NIRS going down while your map looks fine. That's your clue that autoregulation is offline. You're kind of flying manual. So monitoring cerebral perfusion. NIRS again is your friend. Not perfect. For those centers that do it, it's great. Not every one of them do it. It's just, what can you do? You have to work with whatever anesthesia gives you at the time. Again, it's not a perfect, but it's usually a helpful friend. Okay, it's like the coworker that always catches your charting errors and stuff like that. So it'll help you out. Don't just watch the numbers. I've said this many times. I really addressed this in Perf 1000, that you cannot take any one number as law. Okay, you need to watch trends. If the NIRS fall for a little bit, don't panic. Don't go crazy. It's if they're trending downward and staying that way and trending downward, now okay. Now you need to try to figure out why that's happening. But just like anything in the body, something can go down and then some type of compensatory mechanism will bring it right back up. That's how our body works. These organs talking to each other, like Joe said, So don't panic if your NIRS are down, Pair it with your map. That's one way to do it. See where the patient's brain likes to be. Remember, take into account their normal physiology. The patient's normal physiology, okay? That might be different than our normal physiology.
Or the textbook physiology. Yeah.
So remember that if he's chronic hypertension, he might be fine, with a higher map. Or you being at that 60 might not be enough. You might have to be higher. If it's a stroke patient, you definitely need to be higher. So geez, look at history. Look at more than one lab value. Try to compare as much as you can. Again, this is. You guys want to hear this? I've went over this extensively in PerfWeb 101 Day 1, if I'm not mistaken. But the whole story, the story is the story.
Yes, we want to hear the story.
There's no story. Oh. The story is the whole body makes the story. And it's your job to read the story.
No, but I was really glad to see you put TCD on there. Because I am a big believer in TCD.
Yeah?
Huge believer. Go ahead, I'm sorry.
No, you're okay. So, hard autoregulation. Let's move on. I'm in the interest of trying to get through all these. You can spend an enormous amount of time on just the brain. And let me let you guys know, we can spend a lot of time on each one of these organs, but we got a bunch of them to cover, and this is a generalized talk. So
look, it's only 3.1 Category 1 CEU. Okay, you can't get everything in that amount of time.
Exactly.
That's a 40 CEU
lecture.
Event.
Exactly. I mean, you can
That's 4 days.
There could be a 4-day thing on just cerebral.
Yes.
Such, and it has so much research on it. I challenge you all to go to any of these websites like what is the one? I forgot the one with all the studies and stuff. National Bank, National Library, and all that, and just type in cerebral perfusion. See how many hits you get even in just the last 5 years. I mean, they're just still researching this, as they should. It's a big deal. So again, heart autoregulation. Now move on to the muscle that never takes a break, unless you stop it, of course, which we do. So, and then it doesn't like to wake up sometimes. The heart doesn't like to take breaks. So the heart autoregulates, again, between 60, 140-ish, plus minus. But you got to keep in mind, the reason I had brought up diastole is because that is the time that it gets its blood. Okay, it's not going to get it during systole. During systole, usually the pressure is way too high. It's flowing forward. It's not going to come crashing back and perfuse the coronary.
And it's squeezing.
But
you get some.
You do get a little bit.
You do,
but you don't get enough to perfuse the whole heart.
No, of course not.
Because it's going, and it past the ostia. So, and then it'll come back during diastole.
Well, your aortic cusps are opened.
Exactly, and they also like flap over and almost cover them. So.
They do.
Yeah. So. So that means if the diastolic pressure drops, coronary perfusion does too. Okay, this is an important concept that you should always remember, no matter what your flow rate says. A lot of people, I don't want to say perfusionists because we're pretty ingrained with knowing that diastole equals heart perfusion. So we're taught that early on.
But it's
a lot of
diastolic pressure, diastolic time.
Exactly.
I mean, you have to, if you're gonna discuss coronary perfusion, you have to include the DPDT.
Exactly.
Right?
Exactly.
Diastolic pressure, diastolic
Diastolic
time.
time.
And all of that really has an impact.
Exactly.
Yeah.
But see, what I'm getting at is this: is the general public doesn't know a lot of this. Okay, they just think that the 80 is the number on the bottom, and because it's on the bottom, they don't think twice about it. That's just it's kind of human nature. You kind of gravitate towards what's either on top or what comes first. It's just the way it is. So this is why bypass ischemia can sneak up on you at the last minute, on like an add-on case at like 4:55 when you're tired, and all of a sudden, boom, now you got a case. So the red flags for the heart, ST changes, rising lactate, echo showing reduced wall motion, that's the heart telling you, oh, you forgot about me, okay? Tachycardia, low diastolic blood pressure, high left ventricular end diastolic pressure, all of these kind of choke off coronary flow. So the heart is tough, but it's not dumb. So you need to feed it. Make sure you're feeding it properly and at the right times. Perfusion strategy. So support the diastolic pressure, especially when weaning. Optimize flow based on demand, not just on the numbers. Again, use your clinical judgment. Are we getting a good venous return here? How's the perfusion pressure? Is the heart pink, purple? It'll change colors too, just like every other organ. Yeah. So if the myocardium isn't happy, your bypass run will be short, but your ICU state will be long. So
I know.
It's
I know on
and
those
we see
cases,
it a lot.
on those NRP cases we do when we open that chest up and look at that heart.
Right.
It is so incredibly grotesque looking. It's.
I think I was caught off guard by it because I've never seen one until an NRP case.
Mm-hmm.
And I was just like, oh my God, is that even viable? But it's just deoxygenated. It's,
Yeah.
But man, I was just.
Yeah.
And they were talking about taking the heart too in that case.
And how much
I was
volume?
like,
how much volume it fills up with post mortem?
Exactly.
Because it is under tension.
Exactly, and you would think that it wouldn't have as much volume.
Yeah, isn't
what,
that odd?
Yeah, that's like what logic would dictate you towards.
Yeah.
Maybe it wouldn't hold that much volume.
We should do those studies on, because you have to have death, right, in order to measure the mean pressure of the body.
Right.
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 You have to stop the heart in order to do that,
To
just
do
to
that.
see what the baseline mean pressure within the vessel walls, within the body is.
Correct.
And we do that when we do it. We should be measuring that because that is really data that I notice a lot of people are like, wow, we would really love that, but
That would be
but
nice.
we have to stop the heart to figure it out. Well, yeah, we're doing that.
Usually, unless you're not.
Well, it has to stop. Well, does they die? Don't pass, right?
Right.
Go ahead. I'm sorry.
No, you're okay. Joe, jump in, man. Don't worry about it. I think I'm making good time, so we have enough time for discussions too. If you feel the urge to in between, I'm about halfway-ish through this. So the kidneys.
Oh, wow.
These are the fun
Wow.
guys. Kidneys love consistency. They auto-regulate between 80, 180
Here,
map.
more.
Drop below
this.
180, and drop below 80, and they're gonna go on strike. Above 180, they're like, it's like you're pressure washing the glomeruli. You don't want to do that. They'll forgive you once. That's kind of how I said that they are forgiving, but they won't forgive you twice. Mess with their perfusion too long, and you're looking at like post-op dialysis. So
First.
we were talking about how the afferent, the efferent control happens.
Can you stop talking when you're typing, please?
So beyond this, GFR can drop, glomerular membrane can get injured if you're too high, stuff like that, Just remember they're also sensitive to vasopressors, cardiopulmonary bypass, systemic inflammation, such like that, because they'll affect the flow through the kidneys, either by Constricting or dilating the efferent, afferent, those are usually how the blood flow gets controlled by the kidneys. It'll either open up one of those or close one of those, and that's how it controls its own flow.
And the pressure for the ultrafiltration
Oh yeah,
portion of it, right? You have to have
absolutely.
that.
You have to have that transmembrane
You have to
pressure.
have
They
it.
call it, right?
Yeah, you have
That's
to
why
have
we
it.
put the partial bite on the outlet. Coming back to our reservoir, to create a pressure gradient to give you better filtration. So your body does that too. It'll constrict the efferent a little bit so that you
Right.
drive more volume through your glomerulus. Otherwise, not much volume goes through. Don't remember the 20% or maybe a little bit less.
I'm not sure.
I'm
just
not
know
remember the number. I
I
wanna
just
say-
know by the time the blood gets there, the PO2 is 25.
Yeah, I want to say 20% is actually shunted towards the glomerulus, Bowman's capsule, down the nephron and all that. But the other one kind of just comes in, floats around here, doesn't get accepted. It's like, it's like a bouncer. The glomerulus is like a bouncer. He only lets in 20% of the people. You got to be really like high society to get in and get filtered. The other 80% is just boom, boom, right out the efferent and gone. Back into. Try again on next run. That's kind of how it works. But so the body, it's going to control all this by constricting. If it needs more flow, it'll dilate the afferent, bring in more blood. It just depends. Afferent, efferent, for those that don't know, is the afferent's the one that brings it to the nephron. Okay, and the efferent goes out. Okay, so I should have led with what afferent and efferent mean, but that's.
I think everybody knew.
I know, but there might be some, Joe, that don't know.
This is
we
true.
need to play all the audience.
This is true.
So for those that know, I know you know, but there might be some that don't. All right, so kidney autoregulation. Again, they love consistency. They autoregulate usually at a high range, so keep that in mind. Clinical red flags for the kidney, okay? Don't worship the Foley, okay? Usually people love that thing. It's not always a good thing. Your body can kind of get dependent on it. It's not, especially if it's in there long. Infection risk, of course, indwelling urinary catheter is the number one.
No, I really appreciate, though, that you put on here normal map. Urine output decreased despite
normal map.
Normal map.
Absolutely.
That's really important.
Yep. And there's like other causes, like we said, inflammatory agents. I kind of touched on that, which are usually high post bypass, right? So those will also affect you. It doesn't have anything to do with your map. It's just gonna inflammatory agents. Maybe we'll do a lecture on them one day because they're a fun topic.
They are.
We'll do. I'll do one day for the audience.
I like that.
Yeah.
I'll just
I can't
schedule-
get into it now. It's way too broad
I'll
of a
schedule
topic.
it. I'll schedule it next month.
Yeah, let's do
Next
it
month.
Yeah. Well, yeah. Wait. No, let's do it in June.
In June?
Yeah.
Okay.
Yeah. Oh no, you can do it early in the month. If you
Do you want me to do it in May or June?
June.
June.
I'll be
Okay.
done with my vacation in June. And I'll
Okay,
be
very good.
More inclined to give the audience what they need. Before vacation, I'm in vacation brain, So, so you can get a decent amount of urine output and still be causing injury if the pressures are too low or too variable. You can get a rise in creatinine, metabolic acidosis could be creeping in, and that's usually your wake up call.
And of course, you can always mask that by
Exactly.
giving the patient 20 Lasix or 40 Lasix or 100
and which
Lasix.
they do regularly in the ICU.
And just whip the kidneys, beat them
Yep.
to try to get them to make urine in a non-physiologic environment.
Exactly, and they
which
do that
is
regularly in
a very
the ICU.
backwards way of doing it, but we do it all the time.
They love Lasix. Furosemide is everybody's friend in the ICU. It's a favorite player. All right, so perfusion strategies. Again, this is, I'm going to say keep the map above 80, but we're only talking about the kidneys. Also keep in mind that your surgeon may not like it. You may have surgeons, like Joe said, that one occasional one that does like them about 80. Don't chase urine output blindly. Adjust your vasopressors, your flow, your temperature accordingly to what's going on, Also avoid big fluid shifts, aggressive diuresis on bypass, unless absolutely necessary, You're not just moving volume. I've talked about that when I talked about fluid volumes. You're managing vascular tone, perfusion, all that stuff. Your body senses these volume shifts. It adjusts accordingly. So keep that in mind. You know, you want to avoid nephrotoxic meds, of course. You know, unnecessary. Like I said, those as well during bypass. You already being on bypass are putting the kidneys through enough insult. You don't want to introduce nephrotoxic drugs on top of that. And there are a few here and there, antibiotics, things like that are, but that's besides the point, and another lecture for another day. The liver. So, the liver's special. It's, you know, why is it special? It's got a dual blood supply. You know, the portal vein gives it its volume, the hepatic artery gives it its oxygen. It's just different. You know, so the hepatic artery will bring the blood in from the aorta, and the portal vein will bring nice nutrition, you know, stuff from the gut, you know, like where all the intestines and all that will absorb all your nutrition and, you know, send it to the liver. Those are kind of what those two guys do. That's their kind of role in the body. The hepatic artery, so we're not talking about the portal vein because, again, that's just for nutrition. We're talking about hepatic artery. That's the one that autoregulation will be set off of. Which means that if the MAP drops or the CBP climbs too high, you know, you're strangulating the liver's flow. And the liver, you know, it's not going to like it. Keep in mind, CBP is big, you know. People always think only MAP, but CBP can cause downstream congestion, which will also compromise flow and compromise everything.
Or it
lead to ascites.
it would technically be upstream.
It would technically, is it upstream?
Yeah, because
backwards?
it's coming downstream.
Yeah,
It's
okay,
getting
it's
back to
going
the
downstream.
heart to go back out again.
That makes sense.
Yeah.
Behind.
I think. Now, it could be the other way.
It could be the other way.
You know what? Let's not
I think
get
it
into
depends
this.
on the flow of the river.
Let's just keep going.
Let's just keep going.
I
Yeah.
think don't get me into this because I'm gonna end up in the rabbit hole.
Joe can get easily sidetracked. So again, you know, keep in mind that there's something called the hepatic artery buffer response, okay? And that compensates the portal flow when it drops. Portal flow matters too. In the end, you got to remember that while I said the portal flow doesn't matter as much, it still matters, okay? All flow in or out matter, right? And if you don't have both flows uncompromised, see, the portal flow can get compromised so easily. The CBP and all that can complicate it, can cause ascites, you know, and we do this regularly. We deal with patients with heart failure with high CBPs all the time. That's kind of every, you know, 70% of the guys we deal with are like that, right?
Yeah.
I mean,
Anybody? Yeah. I mean, how many times we come off with a patient that has RV dysfunction and they're struggling with
exactly.
the RV, and the next day they're in shock liver.
Exactly.
We all know that's going to happen.
Yep. All right.
And then we're on ECMO.
Don't jinx it, Joe. We don't talk
5
about
to 7
We don't
days.
talk about ECMO.
5 to 7 days to let the right heart come back.
Exactly. And that's if it's going to come back. We've also seen it not come back.
Oh yeah.
And that's tragic. But
Yeah.
that's stretch, man. If you stretch it past a certain point, it's just not going to come back. 2.2 sarcomeres, that's the length, people. So, red flags for the liver. Post-op coagulopathy, that's pretty normal. AST, ALT rising. Those are your transaminases, the elevated transaminases, AST, ALT, as some may know it as. That's not always drugs that do that. You know, you got to understand. Sometimes it's perfusion or lack of it. People like to blame. When you think of AST, ALT, the two main guys that get blamed are like hepatitis, alcohol, viral hepatitis. You know, those are the two guys that you think of. But no, you know, there's perfusion. We can cause this. We can very much cause this. You can be coming off pump and boom, your AST, ALT are way high, and it wasn't that way before you started. And I guarantee you didn't get, you know, it wasn't probably the drugs you gave, or it probably wasn't the fact that he caught hepatitis during the pump run. Like that probably didn't happen, or had a drink during the pump run. So probably was you know. And you can have the power to fix this. So the liver suffers in silent, you know, until it doesn't usually.
And I think it is the most It seems to me to be the one of the most durable. It does seem to take more insult and still come back.
Oh yeah, it's the most resilient of all our organs.
Yeah,
by
clear.
far.
By
You
far.
can really, really give it a number.
You can abuse the liver.
You can really abuse the liver,
once
and
you
you only
cross-
need such a small portion of it to
Yeah.
function properly to be fine.
Yeah. Yeah.
So not only can you damn near eradicate 80% of it and be good with 20, but
Mm-hmm.
you know it can take a beating. It's highly regenerative. It can come back. You know.
it's amazing.
It's probably the most amazing organ,
I know, I wish
largest
I-
organ also of our body if you don't include the skin or the blood.
Of course.
Some will say skin, some will say blood, but if you're not including those in your internal body
Sure.
organs, then boom, liver. Again, you know, usually it can suffer in silence. You won't even know. It's very rare that they would just develop jaundice right there on the spot to know even. AST, ALT, nobody runs those. We don't know. First off, they take forever to come in. NRP cases teach us that. We're sitting there waiting on those sometimes. Some surgeons like to see them before they clamp out. They take damn near 45 minutes to come in. They
Yep.
take a while.
Yeah.
That's because they got to send them to the lab, and it's not an easy test to do. But bottom line is, you know, it's a hard catch, the liver. You know, the only real way we catch it is coagulopathies or stuff like that. So, perfusion strategy for the liver. You know, you want to maintain your map again around 65, 70. That'll cover it. Keep your CVP low. If you're on pump, probably it'll be low, right? As long as you're not filling the heart aggressively with a very high flow rate, your CVP will be low. Most of us go on with some BAVD. We empty the hell out of that heart. So, again, you don't want to slam them with neo or phenylephrine unless you know you're sure that their hepatic artery can take it. Phenylephrine, another fun topic, maybe we can get into one day. It also plays a big effect on the kidneys. I'm gonna stay away from phenylephrine. That's a big talk. As is all vasoconstrictors.
So what do you prefer? Do you prefer phenylephrine or you prefer norepi?
I prefer norepi.
In a word, why?
I feel phenylephrine, norepi. I like diluted norepi. Let me reiterate.
Okay.
Okay. I don't like some of these guys who use like 30 mic norepi. I don't like that. The cases that I've done, I like norepi. It lasts a shorter period of time.
Really?
For my case, man, it is. Usually, I only need it for very select periods of time. Okay, my vasoconstrictors. You know what I mean? Like maybe at the beginning when we go on, I push a little bit. I try to avoid all vasoconstrictors on pump at all times.
Really?
Usually, yeah, that's how I roll.
See, I'm totally.
You're the opposite. I
different,
noticed
yeah.
that. I know. I pumped with you.
Yeah, I don't have any.
You love
I don't
pushing
have-
that stuff.
I don't have any issue with it.
I don't like any meds. And my rationale comes down to the insult of cardiopulmonary bypass. Is we're already putting the body through so much. I try to let the body figure it out, what it needs. And if it doesn't, if it can't, with either maybe a little bit of flow increase, as long as, of course, the body can take it. If my CVP is not high, I'll try to go up on flow.
Or they're not complaining.
Or they're not complaining of it being full on the field. You know, I try to go up on flow minorly. Maybe if I'm at a 2.2 or a 2, I'll go up to a 2.2. You know, if I'm at a 2.2, I'll go up to a 2.4. Try not to go above 2.4 too much. Then if I'm already at a 2.4, then now I'll debate the should I push a constrictor or should I go up to a 2.6 or a 2.5. That's where the debate comes into my head.
Yeah, and of course, you know, the more hemodiluted you are, the less viscosity you're going to have.
And you can go up higher.
Therefore, and that's one of my other lectures,
Right.
is Wassell's formula, right?
Right.
And so, you know, how do you reconcile? You go up to 2.4 index,
Right.
but you got to do something. Your pressure is still 56. You're going to have to do something.
That's different. See, then I would push.
You would.
My whole thing comes down to the renal implications of it more than the liver implications of it. We've already talked about the liver can take a beating. Okay, chances are the liver is going to be able to take.
But
this
is the liver going to? Are the kidneys going to take a worse beating by giving the patient, a little norepi or a little phenylephrine
versus flow?
to get? No, if you can't get your flow any
Yeah.
higher, the hypotension or the medication.
So that is actually a very interesting topic that they are researching like crazy in even today's day and age.
That's really interesting.
That topic, the pressure, versus renal injury due to renal vasoconstriction, right? It all comes down to pressure versus flow, right? Which is the number one argument in all of cardiopulmonary bypass, right? Like, what's more important, flow or pressure? So this is the same argument because vasoconstriction will compromise flow.
Can
Correct.
can.
Can compromise flow, and with that, you are supplementing pressure.
But
So
if
I'm a flow
if
camp
you're
person.
telling me that autoregulation of the kidneys is compromised
At 80.
under 6 to
It is.
I was going to say
so. Flow is
60s,
important
80,
then.
then yeah, flow is really important. Right. So it becomes flow dependent. It
So
becomes
that's
a flow
why-
dependent zone.
That's
but-
why I don't That's why I don't renoconstrict.
But at some point you have to.
Again, Joe, you have
Right.
to read
There's
the
no
situation,
always, right. Okay.
Sometimes you
All right.
got to push.
I get it.
Your map is also important because it's perfusing the brain, a lot of other places too. It's not just about your kidneys.
This is true.
But for me, it comes down to the kidneys, and if I can avoid it, it's because of the kidneys that I do avoid it. It really doesn't have anything to do with, again, our brain, as I told you, has a really low autoregulatory point, so it probably is going to be fine. It's probably going to get its flow. You're not going to impact it. The heart is about the same.
The brain will take the last mole of oxygen left in the
Exactly.
body, and it will
Exactly.
take the last hemoglobin that has that last mole
Well,
on it.
right, and then the heart will take it second.
Actually,
so
it'll technically be 4, but we'll just say 1 for the sake of the argument.
okay. Technically,
There's 4
on each.
on hemoglobin. Yeah,
That's a play on 10.
I thought that was good. I thought that was kind of pithy.
Yeah.
Whatever.
Okay, so yeah. Remember that there are other players involved in this. In the liver, you're going to get high abdominal pressures from retractors. If they do have ascites, that's going to choke the liver out. So there's a lot more going on, again, that you need to think about if they're in that area. So what shifts that curve that I was talking about? Okay, this is kind of where it gets fun. The threshold shifts they're kind of like your favorite playlist on shuffle. It could be so many different things, Hypertension will shift it to the right. Okay, we already talked about that. I already showed you that. That was the picture I showed you. The picture that I showed you had the autoregulation starting at 70, so we're just assuming that was what happened. It could have been something else. Anesthesia usually flattens your curve. Especially in the brain. That's kind of the reason we do it. The brain loses all its electrical activity. All that stuff happens, especially if you induce hyperthermia on top of the anesthesia, which we do most of the time.
Oh, man, in sepsis, I mean, I think it not only
yeah.
abolishes autoregulation, but have you ever seen, for those of you who have not had a chance to see it, you need to look at side stream dark field imaging.
What is that?
It's a probe that goes sublingually because sublingual access to your the capillary bed is very surface. And this can go in and focus and look at a capillary bed.
Oh, wow.
It's a very, very, very sophisticated lens and computer software. And I have done that before and watched and I've seen, there's a lot of images you could get online.
Right.
And when you have somebody in sepsis, to watch the flow derangement through the capillaries with it, you see white cells invading you can see it all.
Right.
Invading the wall.
Right.
Or exudating out.
Right.
And you can see the flow going around bridges and everything real slow and sluggish, even
Right.
though the patient's cardiac output is like 15 liters.
Oh, my God.
It's just amazing to
crazy.
see. It looks like it's barely moving through the capillary bed, but everything is going around it.
You had told me about this, actually.
It is dark. Listen,
I
dark
remember
side
you
stream
told me about
dark
it.
field imaging.
You told me about it.
And I had one of the devices. I had to send it back, It was a guy.
You were like testing it out
in-
or something?
I
Yeah,
was.
you told me
we
about
were.
that, yeah.
We were playing with it, dude, and I
Yeah.
have some really cool images from it.
You told me about it.
If I had the money to buy the device, just to use it for.
We were talking about pulsatile versus
Yes,
continuous.
and
you
dude,
brought that
it
up
was
that day.
incredible. I've got a really good lecture on it. I'll have to show it again one day. I would love to get that device back and redo it because it was just I
Oh,
learned
yeah.
so much, and it was so incredibly. It was so cool to play with it.
What implications does it have medically? What would we use it for though, other than just
to-
research?
To look at, well, I think that it has implications. I think if you're trying to see, you have a patient who has a let's say a chronic acidosis,
Okay.
but you can't really, just a refractory metabolic acidosis, and you're not sure, and you can't find a source, could be generalized, and so you can actually look and see, what's going on, and then you can perform various treatments and see if that treatment is having an impact on the capillary perfusion flow characteristics, which would improve the current situation because your acidosis is because of global, diffuse, generalized ischemia.
Correct.
Yeah.
Right.
So that's
and the production
that's,
of lactate.
Yes,
Right.
I think it has incredible value. Actually, I think
Okay.
TCD has
I was
incredible
wondering.
value.
Yeah. When you
I
first
think-
told me about it, that was the first question I asked.
I
myself.
think it's remarkable. We had started using it for pulsatile flow stuff. Oh, look, Josh actually used it too, dude. You're gonna have to call in here in a minute, okay? Just give us a minute here to get Samir through his lecture, and then we're gonna have you call in because you sound like you're gonna have a wealth of information and knowledge to share. I'm just
Yeah.
loving this experience.
So
We got a really good audience participator
today we
here.
do.
We
I
really
saw
do.
that. I was looking
Yeah.
at it right now.
Yeah.
I think this is the most
Well, it's a
chatting
good.
I've
It's
seen
a
in
good.
a while.
It's a good topic.
It is a good topic.
It's a good
Yeah, we
topic.
have so many things.
Yeah, I know. So, but anyway, with all of that said, it has value for that. But I think
Right.
TCD should be used for every pump run. I think we should always be using TCD on bypass.
That would be
There
nice.
is nothing
Right.
that is more definitive
Mm-hmm.
that an embolic event either occurred
Or didn't. Yeah.
or didn't.
Yeah.
And if you are flowing enough to the brain, you can see the flow through the MCA
Right.
bilaterally.
Right.
So if anything's going on. You can literally see it. And again, it is going to be definitive that an embolic event occurred.
Right.
What that embolic event was, you might not know.
No. Right.
But you will know because defining particulate versus gas is
Right.
very challenging. But you can, and there's a great story. Can I tell you this one story?
Yeah.
And please forgive me, okay, everybody. But I got to tell you this story because it's so incredibly interesting. There was a surgeon in the medical center at Methodist, Dr. Ramchandani, Mahesh Ramchandani. Interesting character, but he does a lot of his coronaries, does most of his coronaries off pump. Okay, and they were measuring TCD on this patient, and TCD actually saved two patients' life there, just there.
Oh, wow, okay.
Just there. Two stories, I guess. So the first one, they keep getting this signal of emboli. The brain, the TCD is just going, brrrr,
right.
and they're like, "What the hell?" They're off pump. They're just sowing the anastomosis. The CO2 Mr. Blower. When they pointed it down at the LAD, the CO2 went right up the coronary, out the coronary ostia, in the aorta, boom, up to the brain. And they discovered that was something that could happen. Up to that point in time, nobody even thought about that.
Right.
So it was incredible to have discovered that occurred.
Yeah.
The other thing that they did that saved a patient's life was they were monitoring the TCD. They were doing a TAVR. The TCD is what first saw that the patient was not perfusing anymore.
I'm a fan
And
of
then
those.
the TCD was being monitored while CPR was in progress, and they knew immediately that the CPR was ineffective. Someone else took over the CPR, and everything changed.
Oh yeah. See.
And so, and that patient ended up getting saved. So you have two patients
right.
one that was going to probably have a major stroke. I don't care that it's CO2 and more absorbable. You can't handle that much gas going to your brain.
Right,
You're going to have
right.
an occlusive issue
Right.
at some point. And number one, and then number two, they knew they had earliest warning of a problem, and then that our corrective measures were inadequate, fixed that, and we're able to keep going on from there. So I think TCD should be a standard.
A standard in.
I do
yeah.
believe that.
I can agree with that. So, what else shifts the curb? Hypothermia, I had mentioned a second ago briefly. It's going to narrow the range. Sepsis, as Joe had touched on a second ago, it basically just does away with it. It burns the map, throws it out the window. It's just does. There is no, there's no more at all autoregulation anywhere because sepsis is global on top of that. So there's a reason all those organs start to fail so quickly.
Yeah, absolutely.
when you have sepsis.
Absolutely.
And there's a reason that you get multi-organ failures, not just one organ failing. They're all going one by one. So a case study. This one, the map is on bypass is about 60. The nears are dropping from 70 to 55. So what's happening here, keep in mind that the patient's baseline map is about 110 to 120. So the autoregulation curve for him is shifted, okay? So what would you do? I mean, I kind of got it written on there, but on this one, you just got to raise the map. You got to play the fact that his brain is just used to higher pressures. So your knee, and you go up to about an 80 to 85, and voila, your nears come back. I mean, it's just, you'd be shocked at how easy the fix can be.
But it's never a good fix if you don't use the tool.
Exactly.
See, we don't, we don't monitor enough.
No, and I did say that you're lucky if they do it. Most anesthesiologists don't.
They hate it.
They don't like the nears. Yeah, I like it. I've always, that's one of my favorite things about doing like DHCA or anything like that. Is then nears becomes essential, and then they have to do it.
In isolation, it doesn't. It's in isolation. It's one tool.
Right.
But in conjunction with these other tools, it's an important component.
To me, it gives you an extra number to look at to know your perfusion adequacy.
I've had to change. I have historically been negative about NIRS.
And you changed.
I have.
Okay. Why?
Using it more clinically and seeing that it actually does work and its value.
Okay. I'm the same way. And
Theoretically, in the very beginning, I thought this is ridiculous. This is nonsense. You're measuring, measuring measuring mixed blood to start with.
Exactly.
Right.
Yes,
and then you
correct.
have confounding factors like the density of the skull, the thickness of the skin, other surface vessels that are going to interfere with what you're actually trying to measure. So there's obviously limitations.
Correct.
And as I said,
And that's why a lot of them hate it, by the way, the anesthesiologists.
right.
Yeah.
And there's, several studies out there, pumpkin or patient, you can literally kill a patient and remove their brain from their skull and then hook a cerebral oximeter or NIRS up to it, and it'll give you a reading consistent with life.
Really?
So, so that's the pumpkin that is actually a study that shows that.
Wow.
And so, it has its limitations, but when
Right.
used in conjunction with other things and your obvious brain
Right.
being able to assess the clinical picture as it is,
Right.
then it has real value.
Right,
And so
right.
you have to use the tool, accepting its limitations, but using it to maximize your ability to understand what you're doing to the patient.
Right. That's true. See? Okay, another case of study. This one is like usually rising lactate on ECMO. So VA ECMO, all right? Patient on VA ECMO, MAP is 70. You feel good, except for now the lactate is 5.6 and rising, which is no bueno.
Infarcted gut. We're done. Close up. Go home.
You're done. That's what it always is post-op. So what's happening here? So in this case, autoregulation's gone. MAP is now meaningless without flow. You know, it could be infected gut. It could be sepsis, even from an infection. It could be so many different things. Autoregulation is gone, so could be temperature issues, could be fever issues, masked. We had a patient like that had
Hemoglobin
a fever
too
masked.
low. Yeah.
Yep, it could be hemoglobin too low.
Yep.
So
Yep.
flow is not, you need to optimize your hemoglobin, increase flow, adjust your vent settings, make sure those are right. Remember that there can be more than one fix. It might not just be one thing. You might not just give him hemoglobin and boom, everything's fine and dandy. You're gonna have to probably change your vent settings on top of adding some hemoglobin too. Or send in some cultures. He may have a fever that's being masked by your
Yeah, well,
heater
that
cooler.
guy that I
That's
had
what
the
I
blood
just said.
cultures,
Yeah.
they're all so far not growing anything.
I know, that's so weird.
That is weird.
That is weird.
Okay.
Considering how sick he is and how, he's septic and they're not growing nothing. That's crazy.
I know, it's weird.
But you were saying yesterday that they didn't check his CSF, which they can't, obviously, but
No, that'd be a bad idea, but that would be
Yeah.
the only
that's
other
the only
thing
thing
you
left.
could do.
Yeah, that's
Right.
the only thing left that
But
they haven't checked.
ill-advised on somebody
Absolutely.
that's on ECMO.
And yeah, right. You're going to want to do that. All right. So, summary of everything we got here. There it is in the. We're not
So
going
a nice takeaway slide here.
Yep. Nice takeaway slide. So autoregulation's the way, the body's built-in protection system. Don't worry. I got this. That's basically what it's telling you. But under anesthesia, bypass, or shock, the message sometimes doesn't always get sent, to the rest of the body. You are also a surrogate regulator. Remember that as a perfusionist. You decide if the organs stay within their limits. You need to understand some of these curves. Understand what can shift these curves so that you can adjust your flows and maps accordingly. Okay, because sometimes the difference between a clean post-op and a disaster is usually it can be something as small as 10 millimeters of mercury, and one decision of ill-timed decision. It can come down to something as simple as that, and boom, now this guy is on ECMO. Something as small as 10 millimeters of mercury. All righty, that's that. Let's take a 5-minute break.
Very good. Well, let's see, Josh.
Okay. Oh,
Josh,
yeah.
if
Yeah,
you're
sorry.
available to call in,
Yeah,
go
yeah.
ahead.
Go
Now's
ahead,
a good
yeah.
time
Let
to
me
do
check
it.
these
But let me tell
questions.
you some of the things that he's been saying. They're really quite interesting.
Okay.
Here, NRP hearts can get gnarly. I think RV
They really
dysfunction
do.
is one of the worst problems with this uptrend in DCD hearts. I'm really interested in hearing that because I'm doing a lot of DCD, and I know that Vanderbilt, and Matt was on from, he's the chief over there at Vanderbilt, the clinical chief. He was on our program, and he's one of the, really the developers of this technique. And Vanderbilt does the highest volume of them, and they have really, really, really good results. I do think that not all NRP is equal. I recently went to a meeting up in Dallas and listened to a couple of speakers talk about their NRP systems and their experience, and it was very, very different from mine, or from the one that we're using with the folks that I'm working with. We're operating on their program. So, Josh, that's a really good question that you've got there, or thought, and I was just wondering: are these hearts that are also going on the OCS, or are you NRPing them and then putting them on cold storage, static cold storage, and bringing them to your location and putting them in? I'm really curious about that and what your experience has been. I know you said you were going to get called in for a high pack, but if you can call, great. But I mean, this is an issue. I think this is a real issue.
Yeah.
And why, one of the things that, CMS is going to look at is, are these hearts getting transplanted and these patients doing well?
Yeah.
Right?
Yeah.
Because it's, this is a newer technique. And I know that
It
there
is
is
new,
some.
and we're still learning.
Yes. And there's a lot of competition between it and the OCS,
Right, systems,
hearts
right,
in a box
right,
type thing.
right.
So I think both systems work. I think both systems have a place, although I believed the OCS's place was for those long trips, but with those two people from last week saying that they had 10 and 12 and a half hours
Exactly.
of
That's crazy.
ischemic time
Yeah, right. That's
on
just-
hearts and didn't have to put those people on ECMO, that's pretty remarkable, I think. He also, Josh also said that getting ready to head in, unfortunately, straight NRP to cold storage, lungs are worse, but I think it's a combo of long ischemic times over extubation period in addition to poor perfusion. Yep, yes,
I agree with
could
that.
could be. Not sure your NRP technique.
He can hear you.
Yeah, I know, but I want to say it for everybody else to read it at some point in time later. But also, you were using the side stream, the dark field side stream imaging from, what was the name of that company? Magic, what was the name of that company?
I need to look at it. And
Micromedics? No, not Micromedics.
I will look at it. And
Yeah,
you will say
Dr. Murtha. It was Dr. Murtha. I remember that was the fellow's name. Just really interesting guy. They're over in Amsterdam, I believe, right? They're in Denmark. I think so. Anyway, but we did it with pulsatile flow, and I saw absolutely no difference at all in any of the flow at the capillary level. So it looked exactly the same. We turned the flow on, we turned the flow off, pulsatile, non-pulsatile, and I did measurements each time. I did this on several patients. Never saw any change whatsoever in the flow characteristics in the sublingual capillary bed.
Right.
So I thought that was quite interesting,
Yeah, that is
that I
interesting.
see that. But
Considering that, a lot of people disagree and they say, oh, well, it
Well,
makes a big difference.
somebody was
and-
wanting to know about pulsatile flow. So if we could, do you mind if I
Yeah.
take just a moment
No, go ahead.
before you start your next lecture and talk about pulsatile flow? Because in pulsatile flow, the problem that you have is, can I draw on this and it'll show up? Let me see.
You might need a different color than black.
Yeah, I need a different color than black. Hold on. That was my fault. How do you get a different color?
I thought you had done it
Oh,
earlier.
wrong pen.
Oh, my God. He snatched my pen, people.
Oh, okay, that's black. Yeah. Let me do yellow. Okay. So here's what the problem is. Here is the size of the aorta. Okay? And it's not to scale. Doing the best I can here. Let's just say this is 2.6 cm. And this is the ascending aorta. You're going to put a 7 millimeter cannula in that, flowing that way, okay? Connected to the cannula, which will flange out a little bit, 3/8 inch tubing. And then it's going to go 3/8 inch tubing for 10 feet before it gets back to the pump. Maybe it's 8 feet. Maybe it's 7 feet in your institution. I'm just going to say 10 feet.
Okay.
Now, your cone, centrifugal cone, sits here. Then you have an oxygenator. The oxygenator then goes this way, of course, and there we are making our trip back. So your pulse starts here. You have to pulse through this, through 10 feet of tubing, and then out a hole that's 2.6 centimeters.
Right.
How are you going to create a pulse that in any way
Right.
resembles a normal pulse by doing that? But what you will do is you will have pressures exceeding 400 millimeters of mercury here, and I've measured them. You will have pressures that can exceed 400 millimeters of mercury here, but we'll say it's a little bit less, so I'll just say less than. We'll do that, less than, okay, in this 400 right here. but it's going to be a high pressure.
Right.
And by the time it gets to this point,
Mm-hmm.
you just have a jet going into a large reservoir, and that is not going to be enough in order
create.
to really create the physiologic pulse that you get where the vessel will expand
And contract.
and then
Right.
because a lot of your pulse pressure is not the initial ejection as much as
When it
it
comes
is
back.
the surplus
Right.
hemodynamic energy
Right.
that you need. So the large vessels might see something resembling a pulse, maybe. It's at least a waveform like that. It's not a pulse, okay? But so you might get this, but this isn't enough to really create
Right.
the capillary pulsatility. But I still, even with the patient not on bypass and after bypass, still didn't see any
Right.
difference in the flow
Right.
at the capillary level. I didn't see a pulse now. It was still the same.
Well, that comes down to the
No.
whole point that at the capillary level, you're not pulsatile anyway.
Correct. But I do think pulsatility is important.
Right.
But not the kind of pulse we are able to create.
Correct.
We cannot create a physiological
physiological
pulse.
pulse, right, we
And I'll
can't.
show you the numbers. I'll show you next week. I'm going to show you guys, or whenever our next program is, the waveforms and the pressures that I got in my system to generate that. And I'll show you the side stream stuff too. It should be
Right.
on that on this thing here.
Okay.
It should be on there, but I'm about to go find it. Anyway, that's my thoughts on that, Josh. And I'm sorry you couldn't call in, but thank you so much for participating.
Yeah,
It was quite
absolutely.
important to us
I was
and
just
really
reading a lot of your
reward. I
stuff,
appreciate
yeah.
it very much. And also everybody that had anything to say, okay? I mean, there were other people too. Ox has been talking. Yasser's
Yeah,
been talking.
I've been seeing that.
We got Nawang's talking. No, we got some good folks today, and we really appreciate all of you. Okay, 5-minute break.
All right.
And welcome back, everyone. How are you? Taking care of a few minor things while we were waiting. Okay, we're going to jump straight into lecture 2, and I held the fort down, so Dr. Samir is going to have an opportunity to give his lecture with a little less interference from me for just a moment. I have to go do something real quick, and I'll be right back. The floor is yours, sir.
Can you guys hear me? Okay, so again, welcome back, everybody. We're going to talk about the phenomenon that, like perfusionists encounter regularly, but don't always, it doesn't always get the limelight that it deserves, reperfusion injury. So picture this, all right? You just restored flow. Everything should be golden, right? The heart should be the surgeon should be smiling, anesthesia isn't giving you like a death stare, and then bam, you got arrhythmias, you got stunning going on, myocardial stunning, you got a rising lactate. And so this presentation is about why that happens, how it happens, and more importantly, how we keep it from happening. So my goal is to make this clear, clinically useful, and a little bit entertaining like I try to do. I hate those lecturers that just lecture. I try to throw in jokes, as you guys know, analogies, if you may, try to make things more clear. So hopefully we walk out of this with a slightly healthier aspect of oxidative radicals, calcium ions. If you're able to do that, I call that a win. So what is reperfusion injury? So it's the cellular equivalent of like kicking the door open with oxygen and nutrients only to find the tissue saying, whoa, 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 we weren't like ready. Okay, like that's kind of what's going on here in a much more complicated aspect. It's a weird paradox. You spend all this time trying to restore blood flow, and when you do, you might be setting off an inflammatory riot. You don't even know it's coming, but it just comes. This happens not because the tissues don't want the oxygen. Let's make this very clear. It just doesn't want to be delivered like a fire hose after a drought. Okay, it's like a rom-com. The reunion ending. It has to be slow in coming. It's got to build to it. That's kind of the way it wants it. These rom-coms don't just end after 2 minutes. They got a bunch of little twists and turns along the way and finally culminate with the kiss at the end of the movie. It's a slow process. An hour and a half to 2 hour process. So, ischemia versus reperfusion injury. Again, I created a little table here for you guys. Not the best table creator, not my forte, but I do what I can. Luckily, I got PowerPoint that creates it for me if I just give it some data. So let's lay out the two villains of this drama, which is ischemia and reperfusion injury. So ischemia is like the slow suffocation, your HCP drops, pH it tanks, ion pumps, they quit because they're like overworked interns, they're just tired, they don't want to do nothing more. Reperfusion is the chaotic comeback. It's oxygen bursts in, kicks the door down, reactive oxygen species ROS, they explode onto the scene. Calcium floods in. It's like, hey, it's basically just kicking stuff down. It's you're getting all these things that the heart just did without, or any tissue would have done without for some time. And now all of a sudden all these things are back. They're wanting to be recognized. They're wanting to turn on processes that have since turned off and new processes turned on. And so they're kind of trying to figure out where they belong in the process. So, key systems affected. Let's talk the body count of what's going to happen here. Reperfusion injury. It's pretty much an equal opportunity offender. A lot of people just talk about the heart. It's not just the heart. It is the heart. That's what we, are mostly concerned about. But it is also other stuff too. In the heart, you can have stunning, arrhythmias, infract extension. That can happen. It does happen. In the lungs, you can get capillary leakage, pulmonary edema. Sometimes full-blown ARDS. That also happens. In the kidneys, AKI, of course, talked about it many times. The brain, you can have ischemia, reperfusion, stroke, edema. All these things happen, you know. And then, of course, the gut, you know. And that's where things go septic. We were talking about that earlier, you know, with Joe and I. If you're not careful, you know. The endothelium is quite like the introvert of, you know, the vascular world. Also, it can get wrecked. And that causes like systemic trouble because where isn't that present, you know? So you got to kind of think of it like tearing the wallpaper off the whole house when you're thinking about the endothelium. It's everywhere, you know? Let's see. Okay, so I threw in this graph in there. In this picture, sorry, of the actual processes. I'm not going to get too into the processes. We'll talk about a little bit about each one. But basically, reperfusion injury is like a four-headed monster. You have to understand. You know, there's the reactive oxygen species, the ROS. You know, they're basically the free radicals that are on a bender. You know, then you have calcium overload. It's like basically like the Kool-Aid man crashing into the cell, you know, like through the wall. I don't know if you guys old enough to remember that commercial. Funny commercial. Mitochondrial dysfunction. The powerhouse kind of goes off grid. There's this fun little pore, the MPTP. It opens up. Lord, you don't want that thing to open up. That's basically that cell calling it quits. It's basically going to get marked for death after that thing opens up. Inflammation, neutrophils kind of show up. They light the house on fire. They're like, okay, you know, let's make things happen. It's chaos. I mean, reperfusion is a very chaotic event. There's all kinds of stuff going on. People just like to think of the oxygen radicals. You know, a lot of people, when they think of reperfusion injury, they only think of the reactive oxygen species, right? I mean, most people don't think about the calcium, the mitochondrial dysfunction, the inflammation.
And that's why I mean, back in the days of just cold potassium based cardioplegia, that it was lethal,
right,
to give the patient calcium,
right,
before the heart reestablished its regular rhythm.
right,
Right.
right.
And but of course, you know, you look at what we did the other day, where we took a patient who came to us massively fluid overloaded in just chronic heart failure, had aortic insufficiency, did not have coronary disease, but did have an anomalous right coronary artery, if you remember.
Right.
And we used Plegisol on that patient. We did not use Delnido.
Right.
And yet we did 10 liters of CVVH with a bicarb-based fluid that had 3 of calcium in it.
It did.
And so, you know, that's going totally against
the stone heart theory.
that concept, right?
Yeah, the whole
And
right.
so,
Don't
you know,
load up on calcium early.
Right. So
right.
So if we had not protected that heart adequately,
Correct.
which clearly we did, then that could have potentially been a problem.
Yeah. That guy was sick.
He was, but he did great.
He did great.
He did great. Extubated and on the floor.
Really?
He did great.
I remember anesthesia was so scared to even extubate him. They were like, but great.
And they were having minor seizures because of what I was doing.
Right.
Because they don't understand it. We also took 6 liters off that patient.
We did.
We removed 6 liters.
Correct.
That patient was so incredibly fluid. And everybody was like, oh, my God, we're not going to be able to get him off bypass. His heart needs to be full. So we're fixing the valve. Okay, so, you know.
You're not going to need as much as you think.
You know.
It's not AI. The valve's just not open.
Maybe that heart just
I remember you
doesn't-
telling the doctor, like,
You know,
don't worry, we're going to have more than enough volume. I
You're
guarantee. You
gonna
had to, like,
have-
assure them, don't worry, we're going to have enough volume.
And we did.
And we did, correct.
We had more than enough.
More than enough, correct. We ejected, we had good
The
ejections.
guy did great.
He did.
And I think this is what I keep trying to tell people is that when I read these articles. I don't want to change subjects here, but we read these articles claiming that ultrafiltration or Z-buff or CVVH
Right.
causes acute kidney injury. I just cannot, in any good conscience, agree with any of it, because it is the study designs are just bad,
Right.
wrong, or they have an agenda that they're trying to push, and what they're doing is literally malfeasant. I mean, it has to be something.
Right, right.
Anyway, go ahead. I'm sorry.
No, okay, no problem. So, reactive oxygen species. Let's think about this. They're like sugar crazed kids at a birthday party. They're short lived. They don't go long, but they're highly destructive for that short lived time that they're there. So during ischemia, where is it? Right here. Xanthine dehydrogenase is going to create xanthine oxidase. Okay, basically, that's going to create something called hypoxanthine, and that's going to create oxygen's free radicals and all the fun stuff. Here's one here, here's one here. OH negative is the hydroxyl radical. It's not a fun one. It's not as bad as some of them. They're all pretty bad. They all have unpaired electrons, and they'll just go around wreaking havoc on anything that has electrons. Basically everything.
It's an electron stealer.
It's an electron stealer. That's the thief in the night, Joe. It just goes around stealing stuff, making that not happy by not being balanced. What it steals it from. So, anyways, when you finally do restore the oxygen, it doesn't just get used, it gets abused. And this is kind of how, you get superoxide. That's another popular one. Hydroxyl.
Superoxide peroxidase.
That one's a really, really bad one.
Bad.
Yeah, bad. That one's real bad. Even the happy peroxide is a bad thing. Like unhappy peroxide. Imagine, I don't know if you guys ever seen peroxide, like regular peroxide. Well, like when you cut yourself, your mom kind of throws
Hydrogen
it on your
peroxide,
skin.
yeah.
Yeah, hydrogen peroxide.
How it foams.
How it foams. It's basically just destroying tissue. It's
it does.
destroying the bad stuff, but oh Lord, what it does on your tissues that it touches, it wreaks havoc on it. And again, that's the happy version of it. That's not even the unhappy version of it, the nastier
version.
one. But so yeah, that's kind of that's hydrogen peroxide's another real big one, like you mentioned.
And when I sit here and listen to this, and I know there's some really smart people out there, and I'm listening to you give this lecture. I was listening the other night to somebody talking about the physics of the subatomic world, and how the physics of the subatomic world are different. The rules are different than the atomic world the world we can see.
Right.
And it's so, I was listening to this, and these people, I'm trying to understand the concept. I'm really trying. And it's like this. This is so incredibly complex.
Yep.
And how these things, happen where we can't see it. We just see the effect of it.
Right.
It's all
right,
we
right.
ever see. We see the result.
Exactly.
But it's really bizarre.
Especially ions and
what we just don't know.
Yeah.
We don't, and that's the problem. The biggest problem we
Yeah.
have, I think, in perfusion and medicine is we don't know, but specifically perfusion,
Right.
we don't know what we don't know.
Exactly.
And we don't know a lot.
No, and you can't.
And we don't even know we don't know it.
We can't be expected to know it either. I mean,
But I don't think-
subatomic physics is a whole freaking subject.
Of
you know
course
what I
it
mean?
is,
Like,
but
it's a big
these
deal.
are right. But these are things that we operate on an acceptable M&M. That's what we. That's
Just enough to get by is what you're saying.
That is what we operate on.
Sometimes not even enough to get by, but we get by.
well, we are compared.
Right.
We are compared to people. If you're in the STS database, we're compared to the rest of the people in the country.
Right.
Okay, and in your geographic area, they even narrow it down like that.
Right.
Are your outcomes the same, expected from what the STS says
Right.
nationally should be expected, or are you outside those values?
Right.
And
Right.
so it's the ones that fall outside of the good outcomes, And the ones that subset even further
Right.
of the ones, what the hell just happened and why?
Exactly.
That's what bothers me.
I know. I feel like we're caught, in a vicious cycle like that against ourselves too, to some degree.
Yeah.
We also don't do anything to make the situations really better.
Well, no, I mean, I've come to a new philosophy. People ask me what I do for work, and my answer now is
I've heard this answer.
I go to work and I hurt people.
Yeah, I remember you telling
But I
me that.
try really hard to minimize how much I know I'm going to hurt them. I facilitate a procedure being done, and in
That
order
will
to
hurt
do
you.
that, I have to do some really unnatural, non-physiologic stuff to people
Exactly.
that they're not going to like.
Right.
And my job is to minimize the amount of trauma that the
Exactly.
patient will suffer and not have them have long-term deficit. That's what I do.
That is what you do. But, the part that I think you conveniently left out is these people would not do well unless you do this.
Well, I conveniently let it out. I mean, I left it off. I didn't conveniently do it.
No.
It wasn't my point.
Like, hey,
But thanks for the point.
these people would probably die unless we do this. We don't just put them on pump for no fun reason. So calcium. Calcium is normally like, the maestro of muscle contraction. That's kind of what we know it as. But during reperfusion, it turns into like a wrecking ball. And people don't, again, oxygen, reactive species, they get all the attention. All these other things, they don't get as much attention, especially calcium. Nobody even thinks about calcium when they think about reperfusion injury, They don't realize how much calcium does, ATP-dependent pumps, can shut down during ischemia. So when blood returns, calcium rushes in so fast that, it causes hypercontracture, myocardial damage, and even it could cause like necrosis or apoptosis. And that's regular. It happens all the damn time. So it's the equivalent of like turning all the lights and all the appliances on at once in a house. Especially all the appliances. So boom, what's going to happen? Short circuit. Your fuse box is going to pop. That's kind of just what happens with calcium. So the next one, mitochondrial dysfunction. Same picture from before. So the mitochondria, everybody knows the mitochondria, powerhouse of the cell. We all taught that early in school. So what actually happens when I talk about mitochondrial dysfunction? I talked about it earlier, the MPTP pore, that little guy right here, it opens, okay? Right here. It's opening. So basically it's like opening an airlock in a spaceship, everything gets sucked out. And boom, what's supposed to be inside is no longer inside. Cytochrome C, it leaks out. ATP generation, it halts. Basically, cell spirals into apoptosis, programmed cell death. That's basically what happens. It's the trigger for it. So the irony is that you need mitochondria to survive, right? But when they're stressed, they basically are the first to jump ship. It's the most hilarious thing about them. They're like, yep, nope, we're out. That's it. We're done. Open the pore, jump ship. Like, that's kind of how it works. So, inflammation, endothelium. So let's not forget about our other favorite guy that likes to go around wreaking havoc, especially when on pump or foreign surfaces and this and that. And that's neutrophils, So those guys don't know the difference between helping and destroying. They're just they just go around. They don't care. They just begin to barge in. They release cytokines, enzymes, and more reactive oxygen species. They're just like, hey. And the endothelium is also, once it gets inflamed, it becomes sticky. It's like flypaper for immune cells, and that leads to capillary leakage, edema, sometimes microvascular thrombosis. That can happen. You'll see those petechiae and stuff like that, It's basically it's the vascular version of like rush hour gridlock plus like a fire alarm. So imagine that. Imagine like you're already bumper to bumper and boom, all of a sudden now somebody pulls a fire alarm, everybody's trying to move, but you can't actually go anywhere, do anything. Chaos. I mean, that's what reperfusion injury is. So the timing of the injury. So if you got 10 minutes after the clamp release to make to make things right before you're about to come off, those 10 minutes, they're sacred, okay? Like, we usually, as perfusionists, got a lot of thing going on in them 10 minutes. We're usually giving some drugs, you're trying to make things right, you're coming back up normothermic, those minutes after the clamp comes off are usually pretty action-packed, okay? And nowadays, surgeons are making our window smaller and smaller, right, Joe? They're like wanting to take the clamp off and come off ASAP, So our little 10-minute happy window of making things as right as they can be, we don't even have 10 sometimes. You got these lightning fast surgeons where it clamps off, you're off in 5 minutes, and that's that. That's just how it rolls. So, think of it like landing a plane. Most accidents happen on takeoff or landing, not during the cruising,
I know. I just recently crashed on landing.
He did, and the story, maybe he'll tell you one day, it's quite a story.
I did.
It's quite the story.
I did.
You did tell him?
No, I haven't told him. It was my last flight, though.
Yeah, he's done with that now.
I flew for 50 years.
Right.
And
See? And
well, that's not true. I landed once with my landing
he opened
gear
up his
knocked down,
MPTP pore. He's done.
Yeah. All I know is I crashed the plane. They are fixing it, but
You were in a field, right? You said you landed.
no, I landed on the airfield.
airfield.
I landed
Yeah,
on the runway, got sideways, slid off the runway, hit an embankment, tore the landing gear off, prop strike into the dirt, bent the prop, had Peyronie's disease after that.
Lord.
And just a bunch of other, mostly cosmetic. Fortunately, I had landed and had slowed down enough that I probably hit the berm at like 30 miles an hour.
Right.
So it was, fortunately low impact. Tore the plane up, but,
Right.
I didn't get hurt. But it was disconcerting because I don't know what I did wrong.
Right. Yeah. No. Yeah.
And they say the
remember you
airplane's
telling
not
me
broken. I was pretty sure the airplane was broken somehow. Like I thought a brake had locked or
you
something.
said they had said everything was normal, though, right?
They did.
Yeah.
But,
See, planes, man, planes. That's why I'm a car guy. So again, reperfusion injury, it's about the same as like landing a plane. It's not just about restoring the flow. It's not just about the takeoff, the landing. It's kind of how you do it in between. So preemptive strategies are big, because these events usually are quick. They happen fast after, first 10 to 30 minutes post reperfusion are usually the most critical. All right, so when will you see this? Basically, you'll see this when the cross clamp gets released. You can see this on ECMO, when you're weaning or flow. You see it in transplants a lot, especially because they have these longer ischemic times, closer to like 4 hours, or even closer to 10 hours, 12 hours now, from what we're hearing. It can go on. So the longer your ischemic time, usually the more craziness you're going to have, because more changes that will happen throughout that time. Basically, it's any situation where flow has been low or absent and then is suddenly introduced. Okay, so have you ever heard the phrase, let's go back on pump for a second. Chances are reperfusion wasn't handled gently. That's a big cause. So real world consequences. What does this actually look like clinically? Myocardial stunning. It looks like the ventricles are on vacation. They're just tired. That very common. Sure, many of you guys have seen this. Arrhythmias, they're common. Elevated troponin lactate, because the organs are yelling at you chemically. That's kind of what they do. AKI, lung injury, brain fog, another sampler platter of symptoms. And don't forget vasoplasia. Basically the vasculature also throws a tantrum. It's kind of normal. They're not tantrum prone either. They like to have their fun.
One of our participants, whose name is
Yeah. I remember he messaged last week.
Said a German perfusionist once told me part of our job consists of injecting bubbles in our patients' vessels. The aim of the game being to get those bubbles the smallest possible. That's probably true.
probably true. I love that name.
Yeah.
So,
That's all I got.
general avoidance strategies. Now, let's pivot to what can we do. Think of this as your checklist for reperfusion with grace. Let's do what we can. Preconditioning, I kind of touched on it. Controlled reperfusion. Drugs that can help. We give a lot of mag. They give a lot of lido. They give calcium. These are drugs that a lot of institutions give pretty regularly when coming off. Some people love the mannitol. Why do they love the mannitol? Because it's a free radical scavenger, amongst many other things, but it basically just goes around sucking stuff up. So these drugs, I'm sure most of you guys are aware of these, and I'm sure your institutions, either you're giving it or anesthesia is giving it. Somebody's giving something, okay? You're not just coming off pump with giving nothing. Nobody does that anymore, especially with the, over the last 20-odd years since reperfusion injury has been discovered and has really took off as to what it is and how we can deal with it. Oxygen control is another one. Keep that oxygen tension curve where you want it in the right place. Temperature management is another one. So I'll go over each one of these a little bit more. Ischemic preconditioning. This is basically the idea that with a few short rounds of ischemia can kind of toughen up, the tissues. That's kind of how they can do. Basically, it's like sending them to boot camp, before the battle. It works through like cell survival pathways, and basically it has real world transplant benefits. And in the OR, it's tougher to apply because in transplants or in elective surgeries, you don't really get that kind of time, that we kind of are just going and flying at the seat of our pants, and that's kind of how it is, So that's ischemic preconditioning. Again, sometimes we can do it, sometimes we cannot. Controlled reperfusion, this is kind of your wheelhouse. This is what we do. Flow pressure, time, stuff like that. Start with low flow, maybe 10, 20%, slowly ramp up. That's, when coming off clamp, they say that this way has been proven, but most people just come up on their flow all the way. It's not really, you don't want to just introduce flow like that, especially oxygen-rich flow to a new area that had previously been oxygen deprived. Avoid sudden perfusion spikes. You don't want to. Spikes are just about never good. Okay, in all of perfusion, you want to ease whatever you're doing. Spikes are never good. Even if you're giving boluses, even boluses in medicine. When I used to give medicine, I used to give it slow. People usually just squirt, and I don't do that. I kind of even my boluses, Joe, I actually push them slowly. I don't know why. It's the way I was taught. Whenever I was giving medicine, again.
But I think that's appropriate in some circumstances, and I think it's
yeah.
in others. I think you just have to use common sense.
Exactly.
Right?
And that's kind of what we perfusionists have to do. We have to read the room.
If you're in the middle of a code,
you're not going to
give the give the bicarb, give the calcium, give the epi, and don't sit there and tease it in.
No,
we're in trouble here.
Right.
So it's got to go.
It's got to go, and it's got to go fast.
Yeah. Absolutely. Our problem is that we do all of this stuff, and what I don't think people really understand well is that we are trying to do so much, and we have such a compressed time frame in which to do it. And so a lot of things a lot of what we do, if you're going to be really good at this job, is to be 2 or 3 steps ahead of everybody else.
Right.
You have to know where you're at, what you're doing,
and you have to know your surgeon.
Sort of adjust.
Or your staff, or
at least
something
know
like
the
that.
procedure.
Right. Because a lot of this research that I looked into it, they say on my slide, I have stepwise increase over 3 to 5 minutes. Well, some surgeons, you don't got that time. Clamp comes off, you're coming off in a few minutes. That's just the way they roll. Especially if you're already warm. Some of them, the only time they're usually waiting on is the warming time towards the end. If you're already warm and the clamp is off, chances are they're going to get the patient off bypass ASAP. So here you are fiddling around with your mag and your lido, and they're already wanting to, come down and off.
Absolutely, yeah. I hear you.
So again, you got to take it with what you can do. Avoid hyperoxia, of course, hyperthermia, hyperosmolarity.
And let's talk about hyperoxia for just a minute. Are you
Okay.
almost done with your slides? Are you close?
We're getting close, yeah.
Okay. Because we're a little early, and that's okay. I just don't want to. I don't want to
Got
go
about
late.
10,
I don't
a
want to
little
go.
less than 10 left.
I don't want to go left. I don't want to go over the time.
Okay.
But I do have to say this. So when we look at all of the different things, rewarming speed and rewarming temperatures are two separate things.
Right.
So let's just look at fundamental temperature. And it's the same thing with your reperfusion and trying not to be hyperoxemic
Right.
or have hyperoxia. Yeah. Is that these injuries you're talking about, this injury pattern requires that you first have ischemia.
Correct.
So when I hear people say, oh my God, the temperature's above 37, and you're committing a crime almost because you're going to cause all kind of brain injury.
Right.
Well, I just had a patient who had a temperature of 102,
And he, yeah.
and it didn't cause his brain to fry,
Right.
right? So on its own, a temperature of 30, and I used to warm all of my patients up to 38 degrees, not 37 degrees. And again, I'm one of those people that I understand how important evidence-based medicine is. I am very understanding of it. But if we all don't come to the recognition that not all scientifically published data is good science nor good data, or how it's interpreted is wrong, we get a very skewed view. So when I would heat patients up to 38, they would so much drier.
Right.
They wouldn't bleed.
Right.
They wouldn't shiver.
Right.
They would go to the ICU and they would do just fine. They would do great, as a
Right.
matter of fact. So minus an injury to the brain, that would require a therapeutic hypothermia.
Right. I was just about to say you don't want to
Freeze it.
dilate them out if they're
Right.
right.
Right. But if they have not had an event, a stroke of some sort, raising the temperature to 37.5, going over 37 degrees, is not going to cause on its own neurologic injury.
Right.
So, be that as it may, I think the same thing applies with the hyperoxia. If I do my cases at 100% FiO2.
You sure do.
I do not turn that down.
Nope. He has
I've
PO2s of 500.
I've been burned
Most
before.
of his case.
I have been burned before.
Right. Well, what do you
Okay.
mean burned before?
Burned where I've turned it down, your temperature starts going up, or the patient
and
gets
your-
light, and the
your
next thing you know,
PO2 is, like,
you're
low.
looking and the arterial blood looks dark,
Right.
and you're not the first person to see it.
Right.
That's an embarrassing place to be.
Right.
That's not
I
good.
think a lot of
That's
perfusionists forget that when you start
that's a bad-
rewarming to go up.
It's a bad
little.
look,
Right. Right.
And well, that's what happens when you have more than one perfusionist doing a case too. That's another thing that I think is a huge mistake.
Mm-hmm.
You got to have one captain of the ship. There's one captain of the ship at the table, and he's technically, or she is technically, the captain of the ship of the room.
Correct.
Okay, but then anesthesia is the captain of their section.
Mm-hmm.
We're the captains of our section. And so you can't have two captains flying a plane. You can have a co-pilot, but you can't have two
Right.
captains. You can't do that. And it won't work.
Right.
If they're fighting against each other about what to do in an emergency, it's going to fail.
Right. And you were assuming that the other one did something that they may or may not have done.
Likely didn't.
Right.
And now you think they did. But
Right.
with all of that said, in the face of an injury, you're going to reperfuse the tissue. Of course, you're going to turn everything down,
Mm-hmm.
and you're going to try to reperfuse that with a PO2 of, let's say, 72,
Mm-hmm.
something that is high enough, but just high enough.
Right.
And then maybe increase that over some period of time.
Exactly.
But when you're not talking about that kind of injury, this whole idea of increased temperature or high PO2 is just a red herring in my view. It's my view.
That's your view.
What's yours?
I disagree with the hyperoxia thing. I feel that to minimize the production of reactive oxygen species, you should. Now, you're right. Maybe my way will set me up for failure. Maybe one day I will forget to go up on my FiO2 when I need to, when I'm rewarming. And you absolutely need to when you're rewarming, because the oxygen you require when you're cold and the oxygen you require when you're warm are two totally different numbers of oxygen, right?
And albeit it's
Right.
only 0.003 dissolved in the plasma, but
Right.
I can show you on the app, in case you got it, where PO2
You-
can be
right.
just enough
Right.
to get your DO2I to the number you need it to be for
Right.
your minimum threshold.
This is true. But see, I'm not looking at the DO2I. I'm looking at the production of oxygen reactive species after
Right,
the
but-
clamp comes off.
But if you're not delivering DO2I,
Then you're going to raise
sufficiently-
lactate. That's different.
no. If you don't deliver sufficient DO2I, then you're going to have an environment that is going to be more ripe for susceptibility
Right.
to reperfusion injury.
Correct. Because
In
you're going to have
which-
an unhappy environment.
In which case, I do agree with your theory. But if you are perfusing the patient at a DO2I, minimum DO2I that we all consider to be sufficient for good, and you've had good pressure, unless it's an embolic event that you don't know about, there shouldn't be any injury. And if it's embolic, it's not going to clear, so that area is going to die anyway.
Correct. You're right.
Okay,
That's
so-
different.
Yeah, so it's a good conversation.
Yeah.
I'm glad we disagree.
Yeah,
But-
I completely disagree.
Well, all right, we're gonna have. Okay, this will be the. Okay, here, look. This is. We're not gonna do it right now, but we're gonna do it. I guess it won't work. There's no inferno today.
Yeah. There's no inferno.
No
today.
inferno today. And of course, Okay, whatever. All right. Well, tomorrow, or no, day after tomorrow, we will be in the Raging Inferno, and this will be topic 1.
There we go. Let's do it.
So we're fighting this one out. I'm
So-
getting out the big guns.
There you go.
So you give me a controller that doesn't do anything.
look,
like
see,
I asked
Joe wants to
earlier
fire
this
so
morning.
bad.
Why do I have a controller?
All right, carrying on, because I got about 10 slides and I got about a few minutes. Okay, so pharmacological agents, I kind of mentioned some of them before. The drugs we give when we're coming off clamp, they're very common. They're almost everywhere. We give antioxidants. They kind of go around cleaning up the ROSs. You can give calcium channel blockers to kind of help with the intracellular overload of calcium. You can give nitro can be done. Gives you some endothelial protection. MPTP inhibitors, not many people that I've seen actually give it, cyclosporin, but it can be given. Steroids can be given, solumedrol, methylprednisolone, whatever you want to call it. All this stuff can be given, anti-inflammatories. Oxygen control, so hyperoxia, see, this increases reactive oxygen formation. The reason I'm glad we talked about it is because I knew this slide was coming.
But
It
but
has
o-
been
but
proven,
only,
Joe.
But only if you have
Right.
So you can't say. All right. So I reject your slide. I'm sorry.
I know you do.
I reject it because
reject it.
hyperoxia increases ROS formation if there is a bed that is oxygen starved. It's not going to generate ROS in normal tissue.
Correct. But the bed has already been oxygen starved. That ischemia is usually the reason we're in this boat.
Not when I'm perfusing the patient.
That's for like the last hour and a half, Joe.
Okay.
What about before that?
Okay. All right. Well, let's go there then.
Okay. So yeah, well, how about we'll skip this slide and we'll save this for our talk.
Okay.
Okay.
For our argument.
For our argument. Yeah,
Because
yeah.
we are going to fight this one out.
Oh, great.
I'm
Let's
fighting this one.
do it. Let's do it. So temperature management, again, hypothermia, it slows the fire. It's kind of, reduces metabolic rate, ROS production. It slows everything down, inflammation, everything. Rewarming, you want to take it slow. Some of these perfusionists, They go a little too fast for what anything too fast or too slow is never a good thing. Again, the body likes the Goldilocks zone.
Man, I just don't cool that much anymore.
Nobody does really.
It's so rare anymore.
Some surgeons still do, like in med center, there's surgeons that still will go to 32 and 28, 32 on cabbages and 28 on valves.
Yeah, no. We just haven't had that experience here.
We don't, yeah.
No.
I mean, ours like to just drift, and even that, like, we don't even have enough time to drift down below 35. Like,
No.
we're usually about at 35 or so. We don't, they'll say drift to 34, but we don't ever actually make it to 34, like ever. pH electrolyte balance, acidosis again, it kind of makes the cells more vulnerable to injury. You kind of got to know that.
You can't get THAM anymore.
Yeah, they don't
So
get
just
them.
take it away because THAM does not exist anymore.
THAM.
The best buffer ever
Bicarb.
created by man. THAM.
Damn, it doesn't got. They don't give it no more.
Tris.
They still write it everywhere. Joe. It's still
Dude.
written in all our books.
Dude.
It's in the Gravely, like the new version of it. They still love to teach
Dude,
it.
I used like 10 bottles of this stuff on a
Yeah.
gunshot wound patient. And unfortunately he died.
They don't
it was
like
a
it.
cop. He got obliterated. But no, I was able to keep his acid base normal
Nice.
without his sodium being 200.
Right.
I mean, it
right.
was amazing at what I was able to do.
See?
But his injuries were just too unrecoverable. He
There
just
you
died.
go. So, with regards to acidosis, try to fix that even before the clamp comes off. You don't want to enter your reperfusion phase with an acid-based disturbance already. That is not going to go well. Try to, as you should be doing anyway during your pump runs, you should be maintaining a good acid-base balance from the beginning till the end. That's kind of what we do. The reason we check our blood gases so regularly. So definitely you don't want to enter reperfusion phase without having this in check. Potassium, hyperkalemia is a classic reperfusion issue. Not to mention it's going to cause you issues when you need to start the heart back up. It's, we had a patient recently that we thought the heart would just come back. It was just the patient that we talked about. That
But his K was high.
what I'm getting at. So everything was just amazing. We had used dialysate. We basically used a bicarbonate-based buffer solution, and we had his numbers looking amazing, except for the K. For some odd reason, his K just wouldn't come down.
Because
We
we were
eventually had
using
to.
4K
we were using
solution.
4K, and I told Joe that. I was like, hindsight, maybe we should have used a 2.5, or even started with a 0. Should have played. We had a 0 with us. We just, which
And we
of
used
course,
it ultimately.
right?
And
ultimately,
fixed it like in 5 minutes.
in 5 minutes, right? But the heart didn't come back because it was 6.2, which it shouldn't, because we're just that far still hyperkalemic. But then once we got it to 5.5, I think we got it down to 5.2, and once we got it there, oh man!
Well, if you remember, you could see that there was some, it was fibrillating, but it was a really slow.
It was.
Wasn't a coarse fibrillation.
No, it wasn't.
And they tried to fibrillate. And how many times did I say,
Give it some
I
time.
know,
Yeah.
and the problem was the heart
Yeah,
was
they kept
distending.
going. They kept going to the paddles, and
And I was like, look, can you just
that's
stop
not gonna
doing
help
Can you just stop doing that? Just
Yeah.
leave it alone for a minute. He needs a little time.
Yeah.
And then we did our thing with the 0K
did.
solution. We got the K down to like
Quick.
under
Yeah.
5.
Yeah.
And maybe 4.85, whatever it was. And you could see the fibrillation becoming more coarse. And I said, why don't you try defibrillating that heart now? And they did. But of course, it started fibrillating again. I said, well, can you turn the pacemaker off, defibrillate it, and then if you need the pacemaker, turn it back on? They finally did that, and it all worked.
And it was.
If
beating
they would just
beautifully.
have listened to me from the beginning, this is 90% of the problem in these cases.
He was like, they just weren't wanting to listen to him.
They just
I
don't
think
listen.
They were pissed off about the 6.2K. they were like, I know the anesthesiologist was, but then we eventually fixed that. So, your role as perfusionists, okay, you're kind of, you're the control of the flow, so you kind of control what's going to happen here. You control your timing, the delivery, you control the oxygen. Or don't control the oxygen, as Joe would. He just sets it at 1, doesn't control shit. He just puts it at 100 and flies. That's how he rolls.
You know what? My cases all do fine.
They do. I know.
I want to I want to go back, and I'm going to do this. I'm going to go back at a hospital where we're recently transitioning from ultrafiltration on every single case to only ultrafiltration on every single case that's mine. So this should be a really easy retrospective study to do.
And we keep all that stuff.
I'm
right?
gonna
So,
take,
yeah.
I'm gonna go back and I'm gonna pull out all of my cases where I know I ultrafiltrated and how much. I'm gonna take everybody else's cases that did not ultrafiltrate at all
And compare data.
and compare the outcomes and just just do it. I mean, I keep telling people this. I value evidence, I value research, I value it all. But nothing that you could show me in that article, some of these articles that I read, you can't convince me that my two eyes aren't seeing what I'm seeing right here, and it's contradictory entirely to what you're writing right here.
Right.
And that's really challenging for me to reconcile, because there's a group of people who are prolific at writing stuff,
Right.
and they publish it in a journal that I don't want to be overly critical of. I'm generally very critical of AMSECT, but I'm really critical of the JECT journal and the degree to which articles going there are scrutinized,
Right.
because there's a lot of stuff in there. I'm not a writer.
Right. That's
I'm not a researcher.
Right.
So I can't
like
claim,
bias stuff, right? You're talking about.
Yeah, it's not just biased, but I mean it's this is some really crappy looking evidence, but you're purporting this to be, this, you're using all of these big long terms of whatever retrospective regression model, blah blah blah, whatever they call these various things, and it just seems like such incredibly complex machinations to have to do all of these fancy calculations for it either worked or it didn't work.
Right.
And I just feel like there's a little too much of that goes on in that journal. That's my view.
Yeah, that makes sense. They try to confuse you by talking crazy.
Well, and I think that they try to drive an agenda.
Yeah. Well,
If
that's
they don't believe in something,
Right.
then they're going to, because they're good at getting things published in that journal. I mean, you want to impress me? Publish some of that stuff in JECT in the either the double ATS or the STS or the Journal of Cardiovascular Surgery or thoracic surgery. And publish it in something. Publish it in a SIO. Publish it in some. Show me something that you're saying these things that I fundamentally disagree with, because I don't see it over here where I work. So publish that in a journal that everyone considers of the highest repute.
correct.
That's how I feel.
Okay.
Moving on.
So again, you want to make sure your oxygen parameters are within where you want them, according, to Joe. He likes his highs. Me, I like to keep them where they need to be. Temperature, obviously, you want to make sure you got that right. Acid-base status, I kind of covered that. That you control. You completely control that, so that's completely on you. Again, communicate with your surgeon specifically if you're not ready for a clamp to come off. That's big. Especially if you're working on some crazy acid-based disturbance, that is not going to go well if you're
you're
super
right.
acidotic. and-
Right, right. But then, of course, they're going to be.
They're not gonna be happy,
I'm
but
not
better.
going to want to leave the clamp on.
Yeah, I know.
Right. I mean, that's just
But it
making the
doesn't take much
ischemia worse.
a metabolic acidosis or something like that. It's not. You throw some bicarbs in there, give it a few minutes.
Well,
then
what
tell
I'll
them to
do
take
is,
the clamp
yeah,
off.
what I'll do is, they'll say flow down. Wait a minute, I'm not ready. Hold on, I can't get the flow down right now, and I'll try to get it all in.
Yeah,
and
there you go.
Then I'll turn it down.
Then I'll turn it down.
What were you doing back there? Just nothing. I'm ready now.
I was getting ready.
I needed to get my chair better.
So reperfusion during ECMO can be subtle, but significant, especially if you're doing ECPR, where the tissues have kind of been on edge. Go slow, monitor trends, adjust oxygen delivery based on the organ's needs, not textbook values. Those don't work well in ECMO, never have. The best motivator for that is we don't even, no place has an official like ACT score for an ECMO. It's just kind of a number that every hospital you go to will have a different number. Transplant specific tips. Well, these organs have been on ice longer than most leftover
Now,
frozen
I
pizza.
would not go on pump with 100%.
Okay. No.
Or I wouldn't stay.
No, you
when
go on
we-
at 80.
When we reclamp, well, no, I
Right.
would put the patient, the recipient at 100, but
Yeah.
then once they got this in
You would.
for the reperfusion, I would turn it down
Yeah.
and really look at it, watch it closely, but I'd turn it
Because
way
it's
down.
been ischemic a long damn time. That's why.
Yes.
Yeah.
Well,
these are-
especially
this
if
is
it's a
different.
12-hour.
Yeah, exactly. This is
Or
like a
10
whole
hour.
different. Transplants are a whole different beast, people.
Yeah.
The reperfusion injury, that can happen to them is big, and you have to remember that in a transplant, especially if you're doing a heart, you've already taken this guy's old heart out. This is all he's got, is this new heart coming in. So you got to be extra careful. So treat the heart kindly, treat these organs kindly. Leukocyte depleted blood, slow flow, pharmacologic pretreatment.
Should we be using leukocyte depleting filters on pump? Should we be using those that
Should.
that
They're expensive as shit, though.
should we? I know. Should we be using that filter? What's it called? The one that the whole blood plasma reabsorption, molecular reabsorption filter. I can't remember the name of it now. I can't remember the name of it. It was real big in COVID. It's for removing inflammatory mediators because everybody that goes on pump is going to have inflammatory mediators.
Absolutely.
So, are we missing a piece to the puzzle that if we had that in line for each case, we could reduce some of these annoying morbidities that we see?
Well, leukocyte depleting filters have been more than proven to work. Most of the time, it's just an economic issue. It's
Right.
It's a cost issue.
But I
They're
mean,
expensive.
but at what point does that, everything ultimately has been, look, we didn't move to membrane oxygenators because of the cost issue.
Yeah.
We were still using bubble oxygenators
Right.
in hospitals. Obviously, when the Maxima still existed, we were still using bubble oxygenators. So in a lot of places. So, everything, well, it's too expensive. We're not going to do that. This works, right?
Exactly.
And eventually it just becomes the standard, you know.
Right.
But it took quite a bit of time to transition from bubble oxygenators
maybe
to
one
membranes.
day,
Or to hollow fiber, microporous hollow fiber, because they're not real membranes.
There you go.
The
See?
Cymed is a real membrane.
So, future directions, a lot of cool stuff on the horizon regarding this. Again, reperfusion injury is still, in the general sense, a pretty new topic. Back when Joe started, they didn't even know what the hell it was. It wasn't even a thing back then. Not when he started.
Never
It's
even
kind of really took off only in the last 20 years or so.
No, more than that.
more?
My first introduction to reperfusion injury came in 1985.
That sounds about right.
And I was in Philadelphia. I was working with Alden Harkin, and he was very, very big on reperfusion injury and this reactive oxygen species and all of that. And at the time, the best thing we had was mannitol as a oxygen radical scavenger.
Correct.
I question its effectiveness, but it
Still
does.
used today by lots of
According to Dr. Harkin, who's a lot smarter than I'll ever be.
Mm-hmm.
I don't know how he's doing now. I wonder. He's an interesting fella, really an interesting guy. But with that said, he's smarter than I am. He's probably right. I'm sure.
Sure, I believe that. So again, remote preconditioning, that's ischemic preconditioning. That's, we can try to, they're looking into more ways to try to increase the preconditioning so that when the clamp does come off or the blood flow does get released, if there's no clamp, it will handle it better. Mitochondria targeted drugs, kind of like the cyclosporin, gene therapy. I mean, that's an exciting new field that they're looking into everything. They're more than even this. They're they're trying to cure diseases. They cured SCID like about 5-10 years ago. Diabetes type 1's on the horizon as the next one probably.
That's incredible.
That they'll get around to getting. We'll probably get to see that soon.
Yeah.
'Cause-
So all those folks with type 2 better recognize it's not going to help them.
Oh no.
They need to stop eating the donuts.
Exactly. I don't think they understand their own pathology. They don't understand it's not a gene defect in
Yeah.
type 2. It's a you did
Yeah.
it to yourself defect.
I know.
Big difference. Gene therapy can't help you there. So other thing is like, ex vivo organ perfusion systems. The
NRP, you'd have to include that as a separate heading.
Yep.
Because they're two different things.
Exactly, which we talked about last week. Big on transplant organs, helps huge. It's been both have been proven already to work. So it's just a question of which do you prefer more like, So in summary, reperfusion injury is real, fast, fixable, can be done. You can deal with it. It's not just a one-size-fits-all issue. It's a tissue-specific, time-sensitive thing. It starts at a specific moment. You have to deal with it. And remember that you need to start dealing with it before it starts. Okay? Especially if you're working on a heart, there's going to comes a time where that reperfusion will happen. So try to get ahead of it. Try to do some stuff before. Don't just wait for that clamp to come off to start trying to fix everything in the little 5 to 10 minutes that you have before, we come off pump. That's kind of, the main thing that you got to stay ahead of it. I mean, it's real. It's going to happen. You can't get away from it. Reperfusion, again, is not a reset. It's kind of a second insult. So, and it's a pretty damaging insult too. So manage it deliberately. And that's all. And as
Excellent.
always, stay curious, stay critical, stay compassionate, and stay caffeinated.
I like it.
Like
this
this.
was excellent. Good work. Very good work.
Thank you.
Very good work. This was great. I'm really enjoying these lectures from you. I'm learning a lot, and I really like your presentation style. I think everybody's being very responsive to it. We've got more viewers with
thank
you
you.
here than with me, so that's good. Make me a little jealous, maybe. But
Jelly
we'll
much?
we're gonna have to change the lighting for Samir and make him look worse.
No.
Yeah.
I look like $1 million right now.
Yeah, I understand. Yeah, and yeah, okay.
I got the right tint right now.
You don't look
going
like
on.
any of the million. You don't look like $1 million that I've ever
No,
seen.
remember that first day, Joe, where I was all blue looking?
Yeah, you're
because
blue. Yeah, you look cyanotic. Actually, you don't. Actually, you look a
A
little
little
bit
now, yeah.
You look a little funny now
I
too.
do.
So I'm not.
But not
sure.
as bad as the first
But I'm
day.
going through some difficult times here in the studio with our lights in the back not working anymore. We're moving the studio. So I'm dealing with a lot of challenges right now, and I can't wait to get this new studio open and start inviting people like you guys, everybody to come out here. I know some of you be traveling from a long way away, but I'd love to have you. With that said, we'll see you tomorrow. You're stuck with just me. I'm really hoping that I can find a willing victim to sit with me, and that way we can chat back and forth. I think I've got some good ideas. My lectures tomorrow are, what are they? Poiseuille's. Yeah, Poiseuille, and which is going to be so easy. But it's going to be fun because there's some pieces to it that I'm going to try to make it as entertaining as I can. And then I'm also going to be doing myocardial protection strategies. Why do we still see RV dysfunction and failure? So we're going to talk about the different strategies. We're going to talk about Plegisol. We're going to talk about HTK or custodial, whichever you want to call it. We're going to talk about Del Nido. We might even go back a little bit and talk about some of the other ones, like the St. Thomas solution or the Buckberg solution or whatever, and look and see what we all have in common still
A lot
today
of these new
with that.
solutions are just based on those solutions. They just
They are.
tweak them,
You
add a
know-
little thing here and there. And
The first
Put their
time
name on it.
the first time I ever used cardioplegia, the first time I used a bag of lactated ringers.
okay,
I added
potassium.
80 of potassium to the bag. The bag was in a ice basin being cooled. and then I took it and I put it on a pressure bag and increased the pressure, and then had it hanging on the pump, a line going up to the field, needle into the aorta to give the cardioplegia that way. And the problem that we experienced with that was that as we would pump up these bags, because they were made with different plastics back then, and they were cold, they would rupture in the middle of this whole thing. And so it was our initial cardioplegia delivery techniques left much to be desired.
Sure.
But we eventually got it figured out. Yeah, but I when I started in this industry, we didn't have cardioplegia. We used intermittent cross clamping.
Yeah.
So
And of course,
they
like the
would-
coronary perfusion, from what I hear, right? They used to perfuse the coronaries.
Somebody had to sit there and hold
Right.
the two perfusers in the left and right ostia,
Yes,
and the perfusionist had a double pump system. It was two pumps with two glass flasks,
Right.
and as bubble traps with a manometer on the top, and just a regular manometer, not a digital, but a analog,
Yeah, right.
and we would give it, and you'd yell if the pressures were getting high on one side or the other, so that the assistant would hold the things different. And we had to do that, so we had to scrub and hold those perfusers,
Oh, wow.
or we had to pump the case, or we had to just first assist. I mean, so we had to do it. We alternated every day,
Right.
with field or surgical field or this.
or
so you either were
back
doing
behind that.
lines in the surgical field or you were doing the pump.
Man.
And it took forever to set the pump up. I mean, it was not an easy task. That
You
everything
must find
took
perfusion
us,
so easy now.
dude. Compared to where I come from, man, it is so.
Like, you
much
must think we
easier.
have it real good.
I must tell you, it's hard for me to feel
Like,
so.
you
but-
lazy guys,
but,
y'all don't know how
yeah.
good y'all have it.
Yeah, but I gotta tell you, man, the number of things we do and the different challenges that we're facing now are so different than they were then.
Right.
You know what we know now, what we do, what we're able to do, is vastly different from those times.
Right.
So I'm pretty excited about it, and I think that, for those of you that might be interested in hearing this, I think the perfusion industry is going to be here for a very long time.
Yeah. Because
But
it's a dynamic industry that keeps changing, right?
but
Like,
you
so-
must be good stewards of your industry, or you will lose it. You can.
Yeah, that makes sense.
It's like anything else. Okay.
All right.
See you mañana. Peace out.
Bye-bye. I'll see you guys on Thursday.
We ended 10 minutes early. Don't tell the board. Thank you.
Don't tell them.
Bye.